Start.
Uh, this is Dr. Daivat here, and I and all the co-moderators and the speakers here welcome you to Pan Ophthalmologica 2025. I think this is one of the biggest digital ophthalmology conference on this planet, and I am so glad to be a part of it. Dr. Vaibhav and his team at Arunodaya Desarat Eye Hospital, Delhi, have been managing this exceptionally, and kudos to the entire team. So We start with the talks today. The first speaker that I would want to introduce today is Dr. Hani Hamza. Dr. Hani Hamza is a brilliant retina surgeon from Cairo, Egypt. And he's somebody who always thrills us with new techniques of vitreoretinal surgeries. So today he's going to talk on different techniques, outcomes, and his surgical experience with managing sub-ILM hemorrhage. So over to you, Dr. Hani.
Okay, thank you very much. Can you hear me now?
Absolutely, sir. Loud and clear.
Okay. Let me share my screen now. Just a moment. Okay, just a moment. Share and this one. Okay. Can you see my screen?
We can, sir.
Okay, perfect. Then we start our slideshow. Okay, just a moment. Okay, sorry for this. I'm trying to make the slideshow.
Yes, sir. So from here, the play button.
Is it played now?
No, sir. Just click on the play button, sir.
What should I click?
We can see the slide.
Yeah.
Okay, I'll stop sharing.
We
I'll
can
share
see the
again.
slide, Durrani.
Okay. I don't know what's everything was ready. Just a moment. That's it. Okay.
Yeah.
And
so you can click the play button that is on the top.
Yes,
top
just a moment.
center.
Yes,
Yeah.
play. Okay, because this was
absolutely
okay.
there.
Okay, I'm
Yeah.
ready now. Okay. So, well, good afternoon, everyone, and thank you for arranging this huge meeting. As you mentioned, this is the biggest online meeting that is being arranged every year. So my talk today would be about sub-ILM hemorrhage, different causes and outcome. Sub-ILM hemorrhage is relatively uncommon and can be caused by a variety of causes, most commonly valsalva retinopathy by staining or repeated vomiting, blood dyscrasias, and we see it very often in leukemias and thrombocytopenias and patients who suffer blood diseases, Thierson syndrome after subarachnoid hemorrhage, when the blood trickles through the optic nerve to the from the subarachnoid space and can reach the sub-ILM. And finally, ocular trauma, whether blunt or by laser, as we are going to see in the cases I'm going to show. Well, in retinal hemorrhages in general, whether in other diseases, it's usually coming from pathologic retinal vessels. But in sub-ILM hemorrhage, the hemorrhage is caused by bleeding from normal retinal vessels. What are our treatment options? Observation in many cases, especially in those with blood dyscrasias, when the blood anomaly is corrected, then the blood absorbs slowly over a period of a month or two. Some have tried the YAG laser, and this actually is followed by vitreous hemorrhage that resolves over a few months, but can result in macular pucker as well. In some studies, TPA and C3F8 have been also tried with variable results. And finally, vitrectomy in non-resolving cases. So let's go through the first case. This is a female patient, 21 years old, after an attack of severe repeated vomiting over 24 hours. 1 month ago, she developed sudden diminution of vision in her right eye, a best corrected vision of 0.1. She has a sub-ILM hemorrhage that was followed up over a period of 3 weeks without improvement. So these two pictures are actually 1 week apart. And you can see there is no absorption of the blood in the sub-ILM space, and there is a wide separation of the internal limiting membrane, as you can see by the yellow border around the hemorrhage. So my decision was to do the pars plana vitrectomy. So it's a 25 gauge vitrectomy, peeling the posterior hyaloid as usual. And I stained the internal limiting membrane, and then I started removing the internal limiting membrane along the area in which it was already detached. So this is quite an easy procedure. And once you do this, the blood is usually liquefied, and like subretinal hemorrhage, it's easily aspirated, and you can see a healthy macula. And post-operatively, the patient has a vision of 1.0. So blood in the sub-ILM space is not toxic as blood in the subretinal space. Moving to another variety of cases caused by laser devices. Laser devices are used in medicine, industry, and military, and the optical radiation from 380 to 1,400 nanometers can damage the ocular structures. We have natural protective mechanisms as the blink reflex and the aversion response when you turn your head away from the light, and this restricts the duration of laser exposure to only 0.15 seconds up to 0.25 seconds. These natural protective mechanisms are effective against low-power laser pointers only. However, retinal injury can occur after prolonged more than 10-second exposure to these low-power pointers. Now, we have high-power laser devices that unfortunately are now available for purchase via the internet, and they are used by youngsters to lighten fireworks from a distance, light cigarettes, or burn through plastic bags. These powerful laser pointers, more than 500 milliwatts, can cause severe ocular damage, and here the natural protective mechanisms of the eye are ineffective against these lasers. So this is a male patient, 24 years old, watching a football game at Cairo Stadium with sudden loss of vision after brief exposure to a green laser light of unknown source, presenting 1 month after the accident with vision of 260. You can see a very confined, organized sub-ILM hemorrhage in this patient, which has turned yellow in color. This is unusual that it changes color, but I have seen this in some of the laser-induced injuries to the macula. Again, vitrectomy. Then I started peeling the ILM, first with a diamond dusted scraper, and then removing the ILM. You can see the compact space that has caused print on the back surface of the ILM. Now I have this blood, very cautious and very slow aspiration of the blood from over the fovea and leaving the eye on air, and his best corrected vision was a 0.8. Another male patient attending a music festival having the same accident, presenting 2 months after the accident with vision of 160. Here the blood remained reddish in color, as you can see. Again, peeling of the posterior hyaloid, which is mandatory in all cases, staining the ILM, and peeling the ILM in the same manner as before. Again, the compact space causes print on the back surface of the ILM, reddish blood. Now this blood is clotted. I cannot leave the patient like that. Started very slow aspiration and fragmenting this blood clot very gently using the diamond dusted scraper. And finally, I have organized blood over the fovea, as you can see, very smoothly moving over the fovea just to move this blood away. And finally, again, fluid air exchange. And the patient again has a vision of 1.0. Now, this is the last case I'm going to show you. And this is a male patient. He's athletic, completely healthy. After severe stress, he woke up with sudden severe loss of vision in the left eye. On OCT, he has both, and ultrasonography. He has a sub-ILM hemorrhage and also a subretinal hemorrhage, as you are going to see in his surgical procedure. You can see the inferior subretinal hemorrhage and the sub-ILM hemorrhage in the center. So I did not have an idea what can cause this. Actually, peeling the hyaloid caused some breaks in the periphery with that eye laser, as you see, then removing the internal limiting membrane. And I found this blood clot in the subretinal space. I started pulling it. I did not recognize that it is connected to the subretinal blood. And this caused a retinal break in this area. Fortunately, it is at the arcades away from the fovea. And I used this break to drain the subretinal blood by injecting PFC, and finally did laser over this break. And this is the post-operative OCT of the patient. You can see on the right side of the OCT the retinal scar at the site of the laser, and he has a best corrected vision of 0.7, but the patient reports that the picture is pixelated. It's not the normal picture, probably because of some toxicity from the subretinal blood. So to conclude, the sub-ILM hemorrhage can be caused by Valsalva maneuver, can be laser-induced, and rupture of a macroaneurysm, which was actually the case in the last patient I showed you. And that's why the blood was connected to the subretinal space. Observation is the primary treatment. The variations in the clinical picture may reflect different etiologies, but regardless of the cause, in absence of macular injury or subretinal blood, vitrectomy for sub-ILM hemorrhage usually has a good visual prognosis. Thank you very much.
I think brilliant, brilliant, sir. Amazing videos as always. You're always
Thank you very much.
lovely. So I just had one question. So apart from vitrectomy, so vitrectomy is definitely a direct way to clean the hemorrhage up. When do you use lasers, like a YAG laser, or when do you? What is the indication of using a laser to drain a sub-ILM hemorrhage?
I have tried laser, I remember maybe 10 years ago in a patient, and actually it ended up in a macular pucker in this patient. So, and one of the disadvantages that the patient will still complain of floaters maybe for 3 to 4 months after that. So I'm not that inclined to the YAG laser procedure.
True.
I think vitrectomy with the modern techniques now, it is relatively safe, can achieve better visual results.
So even if the hemorrhage is fresh or old, basically vitrectomy is the way to go ahead.
Can you repeat the question again, maybe?
So even if the hemorrhage is fresh or the hemorrhage is old, vitrectomy is the answer today.
Yes, vitrectomy is the ultimate solution in these cases. And I think that in patients with Valsalva maneuver, you can wait for them because it can absorb. Patients with blood dyscrasias, you can wait for them because it will absorb. But the laser-induced injury, I found that these patients do not resolve. It either organizes or it remains as it is, as you have seen in the cases I show. Maybe it is because the blood is actually compacted in a very tight compartment over the macula that does not allow absorption.
True. And it might promote toxicity also.
Yes.
Yes. Okay. Thank you. Thank you so much, sir. Thank you.
Very
Thank
nice,
you.
sir.
Thank
Pleasure to have you.
One more question I have, sir. So how long do you tend to wait for it to absorb? 3 to 4 weeks or more than that?
I can wait in the absence of submacular blood.
Yeah.
I mean, it's
Yeah.
only in the sub-ILM. I can wait for a whole month for the blood to absorb. But I usually see the patient every week and make them to do a serial color photography and see if the blood is absorbing or not. If it is not absorbing and it is stationary, then go ahead after 3 or 4 weeks. But give it a chance first.
Sure. Once we did try doing laser once. So it also leads to formation of hole with progression. So after a month or two, you may end up with a hole there. So better to do with vitrectomy rather than planning a YAG.
I'm sorry, can you repeat the question again? It's
No, so I
I've
was just
tried to.
discussing about Dhavat asked about the laser thing.
Yes.
So whether you want to do laser. So I'm just
Sure.
saying that we did once or twice. And what happened was that ultimately we ended up with a retinal break at that area with progressive thinning. So I think laser is not a very good idea. I think surgery is the way to go.
Okay. So I think that is the moral of the talk. Any kind of
Yeah.
sub-ILM hemorrhage, surgery is the way to go.
Yeah.
Thank you. Thank you very much.
Hello? Yes.
Thank you very much, sir.
Yes, now I can hear you well. Okay, can you repeat again?
Yeah. No, so we were just discussing that by doing laser, so there is a
Yes.
risk of causing a retinal break as well. So best is to avoid laser
I mean,
to drain the.
Go ahead.
Okay.
Dr. Hani, that was a wonderful talk. And I think the
you.
moral of the talk was vitrectomy is the answer to sub-ILM hemorrhage.
Yes, exactly.
Yes.
This is
Thank you.
Thank you. Thank you.
Thank you very.
Thank you, Dr. Vikram.
So I would like to now introduce Dr. Zelia. Hi, ma'am. So has Dr. Zelia joined with us? Hello, Dhaval or Akash, can anybody confirm Dr. Zelia has joined?
I think no, sir. She hasn't joined yet.
Sure. So should we go ahead with the next talk, Dhaval?
Yes, sir. Yes, sir.
Hi, this is Dr. Kushal, moderator of the next talk. Dr. Abdullah, have you joined? Hello, Dr. Abdullah. I don't think he has also joined.
No, sir.
So, should we wait for some time?
So Akash, what do you think? Should we wait?
Uh, sure, we can move ahead, sir.
We should move ahead. Sure.
Yes, sir.
Dr. Olivia had joined us a few moments back. If we can contact her, I think we can go ahead with her talk.
Sure. So then we will go ahead with her if she's online.
Yeah, she joined, sir.
Yeah, she's there.
Sure. So we should go ahead with her talk. Yeah.
Meanwhile, if anybody can contact Dr. Abdullah and just text him to join.
Who is moderating for her?
If moderator is not there, I can ask Dr. Olivia to
Sure. You asked her.
start her presentation.
Yeah. Should you
Dr.
ask her?
Olivia, can you please hear us? Dr. Olivia, we are not able to listen to you. We would like
Good morning.
Yeah, good morning.
It's my pleasure to be here presenting on Pan American Pan Ophthalmologica 2025. Thank you for the kind invitation, Dr. Seri. Let me try to share my screen. Can you see my screen?
Yes, ma'am, sir.
Okay, I will describe the surgical management of a retinal detachment in a patient with iris coloboma. A 24-year-old man attended to the clinic complaining of 2 weeks of sudden visual acuity loss in his right eye. He had not associated systemic disease or positive family history. The visual acuity on the right eye was count fingers and on the left eye was 20/40. Ophthalmic examination revealed a bilateral inferior colobomas with keyhole pupil. In the region of the coloboma, we can see the visibility of equator of the lens inferiorly with possible no sonels in this area. Dilated fundus examination reveals a normal fundus in the left eye and in the right eye show a total rhegmatogenous retinal detachment with Heian retinal tear in the periphery extending 4 hours from 7 to 11 and other holes separately. The posterior flap was descending toward the posterior pole. There were no fundus anomalies like colobomatous choroidal. Echosonography confirmed the posterior segment abnormalities. So we propose in this case a surgical repair with a combined surgery with phacoemulsification, pars plana vitrectomy, encircling band, silicone oil, tamponade under general anesthesia. And here, this is the surgery. We began dyeing with triplan blue dye staining, and we make a continuous circumferential capsulorhexis. And we can appreciate at this part, at the hydrodissection, some displacement of the inferior cataract to the contralateral side. At the beginning of the phacoemulsification, we observe sonular absence at this zone corresponding to the colobomatous area. At this point, I decide to leave aphakic the patient and proceed placing the scleral band. A 360-degree peritomy is made. 4 recti muscles are identified and separate and traction with a 2-0 silk sutures under the insertions. A 42-band silicone is passed under the insertion of all 4 recti. The 2 ends of the silicone band are trimmed so that they can oppose each other. The band is secured with a 5-0 mercilin in the 4 quadrants. After the scleral book, a 25-gauge pars plana vitrectomy is beginning using the OS4 vitrectomy system from Oertli. I do core vitrectomy with triamcinolone and posterior hyaloid removal. This is the area. This is a very important part where we can see the Heian tear, and particularly in the area of the corners of the tear, I try to do a peripheral vitrectomy. Vitreous shaving is performed all around the tear. And the advantage of this approach is that I can access to the anterior part. At this part, I do a very slow fluid exchange. And this is the most important part because I don't want the flip of the tear over the posterior pole. I use a soft tip cannula. I use a soft tip cannula, and also retinal fluid was evacuated to the retinal bricks under air. I do laser 4 rows all around the periphery and extended 360 degrees and use 5,000 silicone oil to tamponade. I close the sclerotomies with 7-0 Vicryl, and this is the postoperative patient in an aphakic way 2 weeks after the surgery. We can see after 1 month with contact lens plus 15, he got 20/14, and this is the OCT with the retina attached. After 3 months, we plan the silicone oil removal plus lens implantation with a Yamani technique. And this is the oil extraction. As we can see, all the retina was attached. We can see the 3 or 4 rows of laser around the big tear. And the silicone was extracted. Once the silicone oil is extracted, I use a 3-piece IOL to make a Yamani technique. We can see first the distal optic is introduced by a needle, 25 gauge needle. I pass the distal optic and make the flange. After this first part, I do the second flange in the proximal haptic, and this is the most difficult part, I think, in the Yamani technique. Once it is with the flange, we can center the lens in the middle, and this is the end. This is the pre and the post operative of the lens. We can see it's very centered. This patient is 2400. Once we took out the sutures from the cornea, and we can see where the flange is behind the conjunctiva. The retina is totally reattached. We have a lot of lasers marks, and this is the final OCT of my patient. I want to add to this that coloboma is a rare entity, and a complete iris coloboma can be associated with ciliary muscle pigmentation, epithelium absent, and with ciliary body is often associated with the iris coloboma. In this part, we can see the visibility of the equator, similar like in my patient, when the inferior lens with the possibility of no zones in this area. Retinal gigant tear detachments comprise 1.5 of rheumatogenic retinal detachment, and it's a very low incidence of general population per year. Finally, perfluorocarbon liquids increase primary attachment rate because they unfold and flatten the posterior retina, and subretinal fluid drainage is increased because of them. But they have been associated with some complications like inflammation, subretinal migration, and toxicity of the inner retina or RPE. This is a publication that they are searching about perfluorocarbon liquid-free vitrectomy for primary rheumatogenic retinal detachment. And they can see some advantage of this free vitrectomy, avoiding retinal toxicity, reducing surgery times and costs, and minimizing intraoperative manipulation with the risk of PFCL migration into the subretinal space. Finally, I want to conclude that the advent of innovations of modern vitrectomy techniques improve our anatomical success in the management of gigant retina tear detachment. It's important to consider the impact of surgeons' experience and skills over the time, and the cataract and gigant retinal rheumatogenic detachment associated with coloboma are complex surgeries. We need combined techniques, and with these associated techniques, we can have optimal results. Thank you.
So excellent talk, Dr. Olivia. Very nice surgery. Very good to see. So I think you did mention why you did not use PFCL. So that is the reason you never use PFCL, or in this particular case, you did not use the PFCL, or that
In
is
this
now your choice.
Yes, no, I definitely like and love PFCL liquids, but in this case, I didn't use. I left the PLC liquids for when I need. I think in this type of surgeries, less is more. So if I can avoid to use them, I do, but if I need them, I ask for them.
great surgery with great results. So thank you very much. So we have any other questions
Thank
for
you,
Dr.
ma'am.
Olivia?
I actually have a question for you. Band buckle definitely will give a great support to the periphery retina for the attachment. But in case of a giant retinal tear, there are more chances of the posterior edge of the retina to slip over the band and then fold in itself. But still, you went ahead with the band buckle. So that's my question. Why actually did we, what was the indication? Thank you.
Yes. Thank you for the great question, Somi. I think that the role of encircling buccal in this type of patients is controversial. There is a potential benefit of reducing the residual vitreoretinal traction related to the postoperative contraction of the vitreous base. But on the other hand, it's true, indentation of the buccal could eventually induce intraoperative slippage of the posterior flap or tear. The choice of which patients may benefit from a supplemental scleral buccal is generally driven by the operative exam findings and the surgeon preference. In this case, I love scleral buccal. When I have a difficult case, I prefer to use it, and I have never say I didn't want to use it. Always when I don't use and I have a retinal redetachment, I wish I have used it.
Thank you, ma'am. Thank you.
Thank you.
So now, thank you, Dr. Olivia. We'll go ahead with our next talk. So I think Dr. Zelia has joined us. So it is my, hello, Dr. Zelia. It is my privilege to introduce Dr. Zelia Maria Correa. She is an internationally renowned ocular oncologist with over 2 decades of clinical, surgical, and research experience. She has been instrumental in shaping ocular oncology practices worldwide. So we welcome you to Pan Ophthalmologica, ma'am. Looking forward for your talk.
Well, thank you so much. This is a real pleasure to be among such esteemed colleagues, people that I know so well that have inspired me and have taught me a lot as well. So I think this is a beautiful forum, and thank you for putting this together for us to exchange knowledge and experiences and very, very impressive cases so far. Anyway, I would like to share my screen now. And I am going to, let's see if this works out, and it did. There we go. So can you all see my slide?
No, ma'am.
Yes.
Your skin
Not,
is not visible.
Not yet. Okay, so that's not working. So it's going with the PowerPoint. All right, so let's not do that one then. Let's share again. Okay, let's try this. Is that better?
yes, this is perfect.
All right, thank you. All right, so I was asked to bring out a topic, and I thought, why not vitreoretinal surgery in primary vitreoretinal lymphoma? Because in reality, primary vitreoretinal lymphoma is much of a masquerader and something that we do see in our offices quite often. And I got a lot of people coming to me and saying, gee, I did this beautiful case. I did this awesome vitrectomy, and then I didn't get a result from the lab. The lab said there's nothing here. There was no way that this could be diagnostic. So I'm going to start, and I'm going to share 2 cases with you to illustrate the challenge of dealing with vitreoretinal lymphoma. The first one is this 51-year-old female that was referred for a second opinion because she had a recent vitreous biopsy that was concerning but not conclusive for vitreoretinal lymphoma. She had a history of a chronic intermediate posterior uveitis. She had been on and off steroids for a long time, and she had this history of severe headaches and negative uveitis workup and normal brain MRI. In the examination, you see she had very faint, 3+ maybe vitreous cells, but there were no clumping. And this was the eye that had had the vitrectomy, that had been on and off the steroids, and the vessels looked normal, and there were no chorioretinal lesions. There was no clumping of white cells. It was really very bland and inconclusive. So this was the result that the outside vitrectomy showed. And, the PCR was negative for monoclonal cells, and the pathology showed atypical CD20 positive B cells that were concerning for a B cell lymphoproliferative disorder, but it wasn't really kind of conclusive for a lymphoma. We asked for a repeat MRI, possible spinal tap if suspicious, and to taper her steroid and come back in a month. 3 months later, she looked fine. She had, 20, 25-ish vision, and she had these little pinpoint small chororetinal lesions supranasally. And that was it. And the vitreous was clear. On the fundus autofluorescence, you can see it right here. It's very mild. I mean, we couldn't pick up anything on the OCT. And we said, okay, let's repeat the vitrectomy because, we did the vitrectomy on the right, although she was showing stuff on the left because since the left had not been operated on, she did not want that left eye touched. And then, we got this, abnormal panel with 29% of cell rearrangement, but it was insufficient for this MYD88 analysis. And the MYD88 here in the United States still is something that many people use as a surrogate for not having to do flow cytometry and not having to do other tests that require a lot of vitreous, like a lot of material, undiluted material. However, these findings were still inconclusive for primary vitreoretinal lymphoma and were more consistent with the B cell proliferation and probably an inflammatory process. I sent the patient back to uveitis, and uveitis could not handle her, sent her back to me 2 months after the second vitrectomy. No evidence of intraocular inflammation, but new pinpoint lesions now in the right eye, right here. I hope you guys can see that on the picture. So this is 1, 2, 3, very teeny tiny lesions. Still, the fovea was fine. Everything was great. Well, surprise, surprise. A month later, she showed up with this on the left eye. Then I said, okay, gloves are off. This is definitely a vitrectomy case. We need to go in, we need to biopsy. And we had her scheduled for a vitrectomy, biopsy, and methotrexate, but she canceled the surgery. She said, there's no way I want anybody to do anything with my left eye. She was a very difficult person to talk to. She was starting to develop a mild cataract on the right eye from the 2 vitrectomies that she had. And this is what we had in front of us. A lot of discussion. We talked to neuro-oncology. They did more tests on her, couldn't find anything. And then we drew up this big consent and said, fine, we're going to treat this medically. So after 2 methotrexate injections, this is how she looked. And she did really well. And we thought, okay, this is it. We started treating the left eye as well. Once she showed up with these spots, so she got better on the left, then the right got worse. And then we treated the right eye as well. And we thought, okay, we're at the end of this. This has been going on for 1.5 years. And when we thought it was fine, a month later, she had brain lesions that were suggestive of CNS lymphoma. And, the spinal tap was conclusive, and she started on high-dose systemic MTX. She also got rituximab. She went on to have oh my gosh, I'm escaping the words here, but she had a bone marrow transplant after they finished the treatment, and she's doing great. But this is a story that evolved over 1 year, and seeing this patient every month being very tiresome, just to show the complexity. Now I'm going to show you a different case, and this case is a gentleman that, showed up in my office with a recent onset of blurred vision, 20/80 on the right, 20/30 on the left, and you can see the 20/80 eye, right eye, with a lot of cloudiness and a very dense, very clumpy vitreous. And on the left eye, he had similar, those little pinpoint lesions that you can see on the fundus autofluorescence quite well. This was his OCT at the time, November of last year. And you can see, really look at this. This is just the cellularity and the vitreous causing a cloud that shows in the OCT. And the little pinpoint lesions here, you can see the regularity there at the level of the RPE. And this is very classic primary vitreoretinal lymphoma. Nonetheless, we said, okay, we got to do a vitrectomy. We can't do this. We can't treat you without a vitrectomy. And we decided to do the vitrectomy on the right eye, although it looks rotated, but that's, that was the eye that we decided to do. And it's very interesting because you see there, first we go for 1 ml of undiluted vitreous. So the way I do that, I close the infusion and I have my assistant on the side with a 3 ml syringe kind of aspirating that vitreous. And when we get to 1 ml, we stop, we open again the infusion, and then we get another 1 ml. And I try to go for the areas where I see the most cells. And there you see doing a detachment of the posterior vitreous and removing all of that. And then you see little kind of clumpy lesions that were actually on the surface of the retina, and that I go there afterwards to aspirate and to remove. So what do I do? So the undiluted vitreous goes to the MYD88 testing, the minimally diluted vitreous. So you see there, I'm taking out the little clumps there. There you're going to see one out. So, and at the end, I do the methotrexate injections and I cryo all the sclerotomies. So this is his recent follow-up, 9 months post-vitrectomy. He's doing great. He's now 20/20. We did 6 injections, monthly injections of methotrexate to both eyes, and he is doing really great in both eyes. He developed a very, very mild ERM, but it's not progressing. It's quiet. So this is what I want to share with you. What is the secret in a vitreous biopsy? First, the 3-port vitrectomy, I prefer the 25 gauge, although a lot of people say that 25 gauge will destroy the cells. But the trick here is to use a very, very low cut rate and to have your assistant aspirate. Don't put the cells into the cassette. Don't put the cells into the machine. Because as you take that 1 ml of undiluted vitreous through a syringe and not the machine, you immediately put it on ice and you immediately send it out for testing, okay? So low cut rate, manual aspiration, 1 undiluted slide, 1 ml undiluted, 1 ml minimally diluted. This one goes to cytology or flow or whatever the pathologist wants to do. But the MYD88 has been shown to be very sensitive and easier or more it requires less specimen than a flow cytometry would, and even the cytology per se. So then whatever else is aspirated, you send that cassette sample immediately because the cells cannot sit around. The vitreous is very delicate and you're going to get just vitreous debris if you let that thing sit for more than 15 minutes after you finish the case. And try to be very quick about the case too. Don't stick around. You're done. Just send out that cassette, take it out and send it off to the pathology lab. Subretinal biopsy can be done. It wasn't the case here, but it can be done using standard biopsy technique and, hand carry the samples on ice to the pathology lab, as I said. We know there are 3 different types of lymphoma, intraocular lymphoma, and it's important that you know what you're dealing with because MYD88 is going to be helpful for primary vitreoretinal lymphoma, but it won't be helpful for uveal lymphoma or secondary lymphoma, which is the case on this ultrasound here that I'm showing. This is a patient that had lymphoma elsewhere, and we deemed that this was a secondary or a metastatic lymphoma to the choroid. So the cells that we get from the vitreous on the cytology is these very large pleomorphic lymphoid cells with a lot of degenerated and scattered kind of pycnotic cells in the background. So keep in mind that the normal vitreous we shouldn't be finding many cells. So a lot of times the pathologist will call me and say, well, I just see this necrotic background. I don't see anything other than this. But this is diagnostic of intraocular lymphoma. So that's important to bear in mind. So it's important to remember that this is a large B-cell non-Hodgkin's lymphoma, and this is a CNS. So this is a brain lesion, as you can see. Remember that, the lymphoma is usually there in that, sub-RPE space. Here's another case that I managed a few years back with really extensive, subretinal infiltration, the screaming infiltration. And the key take point here is no matter how beautiful a surgery you do, no matter how effective your intravitreal chemotherapy is, you need to have neuro-oncology working with you, because 56 and up to 90% of the patients that have primary vitreoretinal lymphoma will develop CNS involvement. And this is very, very, very important, very significant, right? So keep that in mind. Keep in mind that although the cytology is the gold standard, but this MYD88 has a therapeutic potential also, and we're looking at the IRAK4 inhibitors, and this may be something for the future here for us. But the brain MRI, and if there's a suspicious brain MRI, a lumbar puncture is very, very important, and plus minus bone marrow biopsy. So we've talked about this, but remember, we were taught that we want flow cytometry, but the problem with the flow cytometry, it's that it's limited by sample size, and especially eyes that have been already vitrectomized once, it's very difficult to get a good quality sample at the volume necessary to yield a positive result. I just wanted to share with you a little bit about the MYD88 mutations because they are present in approximately 70% of all vitreoretinal lymphomas, and it leads to the activation of IRAK4, which is a receptor, one of the kinase receptors, and that has therapeutic implications, although we still don't have a treatment that is directed for primary vitreoretinal lymphoma. This is something that we're looking into because this is highly specific. And the treatment options, external beam radiation therapy, that is great, but it is a good option in absence of evidence showing any advantage to local chemotherapy. EBRT remains the first line of treatment, especially for patients that have bilateral involvement. So that's very important. Remember the ocular complications of external beam radiation therapy, very important. They can come down the road. One of the things that our predecessors didn't worry about very much is that most people that had primary vitreoretinal lymphoma and then CNS lymphoma, they didn't have a long survival. Stop, because now that we have all of these new treatments, this is changing very rapidly. And we're seeing these patients survive 5, 10 years. I have a patient that I treated 8 years ago, and she just came in to see me, and I looked at her and I was like, what are you doing here? I didn't expect her to be here. But we need to think about that, because our treatment today may solve this little problem, but can become very problematic down the road. And, there's a lot of people that have made very strong arguments for external beam radiation therapy, and they feel that this is great, remembering the local failure is less than 10%, and the chemotherapy, you may have to touch it up later on. But again, I think that's a great discussion, and something that, vitreoretinal surgeons that are managing these cases should be talking about, and we're not talking enough. And intravitreal chemotherapy was started by the group in Israel. They did really amazing seminal work about methotrexate intravitreous. They had a lot of complications because they were treating the patients very vigorously, very frequently. And now we know that we don't need to do it as vigorously as they did in their initial work. So we can avoid a lot of stem cell deficiency and other corneal problems. And this is the protocol. There's an induction phase twice weekly for a month, then the consolidation once weekly, 1 to 2 months, and then the maintenance, which is monthly and 9 to 12 months. I usually treat on when we get to the monthly, then we get to just 6 months. I don't treat that intensely anymore. And the ocular morbidity, as you can see here, the main problem is really cataracts. Rituximab is another option, and we use 0.1 ml, which is 1 milligram, as opposed to 400 micrograms of the methotrexate in 0.1 mLs. And, it really is a great option, especially if the patient has some resistance to MTX, and it's definitely a good option there for you. And the systemic chemotherapy, I don't need to get into that very much because this is something the neuro-oncologist or the hematologist oncologist will take care of. But it's important for us to understand what their pillars are. And still, high-dose systemic methotrexate seems to be the stem treatment for this. And this is the summary of my recommendations. Obviously, if the patient has unilateral disease, intravitreal methotrexate is great. If there's a relapse with methotrexate, rituximab is a good option. If it's bilateral, do consider EBRT, but remember, low dose radiation. And if there's relapse after EBRT, you can still do intravitreal methotrexate. And the systemic therapy, if indicated, if there is CNS involvement, it will reduce the risk of other problems. And, some centers are treating the patients preemptively to reduce the CNS involvement in patients that have ocular limited disease. You have to consider the patient age, the patient health, and what that's going to do to them. And I thank you so much for your time and attention.
Thank you very much for that excellent talk, ma'am. And thank you, first of all, for choosing this interesting topic, because it's always such a difficult task to diagnose this entity, and especially, as you said, to collect the samples. And I just have a few questions regarding that. So you said you use low cut rate. So at what we are talking in about hundreds, or it is in thousands?
I didn't understand your question, Dr. Vikram, please.
You use low cut rate.
Yes, I do a lot of intravitreal injections, intravitreal treatment. We are very fortunate that our cancer center is across the street from Bascom Palmer. So they prepare the medication and somebody from pharmacy walks over and hands it to us. So, we don't have the problem of storage and maintaining the drug. All of these cancer drugs, they are better if they're mixed or diluted right before you use it. So I do use it even in bilateral cases when there is not CNS involvement, but I'm always working with the neuro-oncologist. Although some people feel if the patient lives very far away and is not able to come for all the injections, that external beam radiation therapy is effective and is more effective than the intravitreal injections. I think this is something that really is in the hands of the surgeon and how easy it is to get the medication necessary in a timely manner and the patient to come in for the injections as recommended.
True. Also, ma'am, you said that you keep a low cut rate while collecting the sample. So you're talking about hundreds or it is in thousands? What exactly are the settings for that?
The cutting rate.
Yes, ma'am.
Rate. No, it's in the hundreds, in the low hundreds.
It's low
like
hundred.
really
Right.
slow, like vitrectomy from the 90s, early 90s. It's like chuck, 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 really, really,
Right. Yeah.
really slow, because what you don't want, if you start, kind of cutting very quickly, you're going to macerate the cells. And the
True.
idea is you don't want to traction that vitreous too much, cause a problem. But at the same time, if you cut very frequently, you're going to really be kind of chewing up the cells. You're not going to be able to get a result, right? So the key here is to have a very, very low cut rate and have your assistant aspirating. So you go in, closed infusion in the hundreds. I have a very low setting just for that. And,
Okay.
I go to the area where I see the vitreous is the most dense. And so I hold my vitractor, and that's what the video was showing. You saw that I go in and I kind of try to find where that cloud is. And then I start going, and my assistant says, okay, 1 ml. And I take the instrument out, and the assistant even aspirates whatever is in the tubing. That gets sealed, and that goes to MYD88. And then I open and close the infusion just to reform the eye. And then I go again to a cloudy area. And so
Right.
this is a minimally diluted specimen, and that's what I send for the, either cytology, which in my hands and our pathologist's hands has been better, but the uveitis folks, they like flow cytometry, which you need more than 1 ml and preferably undiluted, but it has worked with the minimally diluted because of the targeted sampling that I do.
Right.
Does that
And I saw you will not do interleukin levels, ma'am.
Pardon?
You don't rely on interleukin levels like IL-10, IL-6
So
levels.
yeah, so that the interleukin levels are tested when we test the flow cytometry. So
Right.
it's all part of the same test. And what I'm saying is that you need very high quality and relatively large volume for them to yield a positive result. So what some of my colleagues do is they do the undiluted specimen. They don't stop, they kind of hold on to that syringe, they open and close, and then they get another ml. And then with 2 mLs, then you're definitely going to get a good flow cytometry. So you mix a little bit, it's minimally diluted, but that's what some of my colleagues that prefer flow cytometry, that's what they do. Does that make sense? Do you guys understand what I'm
Sure,
saying?
sure. Yes, ma'am. Yes, ma'am.
Instead of
Also, I
having
think
two
that also limits
samples,
the AC
yes.
sampling also, because you cannot take that much sample from AC, from anterior
Yes.
chamber.
Exactly.
Yeah,
So have been
yeah,
studied too using the MYD88 with aqueous, and
yeah.
it wasn't as predictive as the vitreous sample, but they showed that it was very helpful as well. I think it was I think it was like 65% that they were able to get a readout.
Yes. I just have one more question, ma'am. So in your first case, I think it was the first case, the lady who did not want it earlier, she had very minimal precipitates, but then she came up with very clear clinical subretinal precipitates, which were like, we will say that that was now diagnostic of lymphoma, PVRL. And could we have started systemic therapy at that time when she
No,
did not have any MRI brain changes?
I
But is
I
that the role of
I hear
systemic
what you're
therapy?
saying. I hear what you're saying. And trust me, we turned her literally upside down, inside and out. She was seeing, 4 different doctors every month. And she was complaining, but we couldn't find it. The OCT couldn't find it, 2 inconclusive biopsies, nothing
Hmm.
on the MRI of the brain, nothing. She even had 2 PET CTs, nothing. And she
Right.
would be complaining, like something is wrong with my eyes, and we would see that minimal flare and we couldn't quite put our finger on it. And I'm sending her back to uveitis, and I'm like, you guys, well, we already tested everything. So it's just for some reason she had this, some kind of very minimally clinically relevant symptoms way earlier than the actual presentation. I mean, that whole time, I think I was seeing her for, I don't know, 6 months plus,
Yeah.
almost 8 months, until she developed the real lesions in the left. And then
Yeah.
we started treating the left, and then she showed up on the right. And I was like, oh my gosh. And then subsequently in the brain. Now, how do you catch these cases? I don't know. I really don't know. We took her to tumor board, and nobody had a good answer for us. But it illustrates how, even if you can't find anything, never send your patients away. Keep them close, because eventually things will kind of show themselves.
Yes.
Oh, okay, yes. So Dr. Vega from Brazil, she's asking me to highlight the importance of that cryotherapy at the sclerotomy site. And it is very important because although we do a very comprehensive vitrectomy, we don't know that we are, not spilling any abnormal lymphocytes, any abnormal cells into the subtenon's space. And that could be a problem, right? Because you can have a recurrence in the orbit, and especially now that we use quite a bit sutureless vitrectomy. So you saw when I put the cotton tip, I should have kind of edited the video to show that I hold the cotton tip and then I put the cryo right on top of it, pull the cotton tip out, and I do a pretty wide sideways, a pretty wide cryotherapy just to make sure we don't have any leakage. And as I said, I do like the 25. I think it's a good compromise between a 3 and a 27. And I haven't used 27 because I think the likelihood of destroying the cells is much higher.
So, and do you do cryo after injections as well?
No, not after the injection, because I use a
Okay.
32 gauge needle, and I am prepared always to tap the anterior chamber. So anytime, yes, sure thing, Dr. Vega. It's so every time I do the injection, if I see the eye is too tense, I don't let it sit like that. I go and I tap the AC. And I don't aspirate any aqueous. I just go in and out just to release that extra fluid. And this way, there's no reflux from the from the vitreous chamber into the subtenon space again.
Can I ask one question if we have time?
Sure,
Yes, yes.
absolutely.
Yes, for sure.
So if it is diagnosed as primary vitreoretinal lymphoma, like what is your protocol to start systemic chemotherapy if there is no CNS or systemic involvement? Do you start with or you wait for some involvement of system and then you start?
So that's what I was touching on at the end. So there's two schools of thought, right? And I have here the hematology oncology team. They, half of them, they wait for any CNS involvement to show. But the neuro-oncology team has been advocating, and in a few of the hemonc, they're advocating for starting as soon as you have vitrectomy confirmation to prevent the neural, effects. I'm conflicted. I'll just say that. And I'm conflicted because some of the patients do very well, like that second patient that I showed that I did the vitrectomy, he did really, really well with the preventative treatment and everything. He had the full shebang and he did very well. He's 20/20, he's super happy. He still has his lenses. He didn't get a cataract. Yeah, so Dr. Vega is saying, isn't it too late to wait for neural lesions? Yeah, that's a questionable thing. But that other patient that had been kind of dragging on for a year, it almost killed her, even though we were already treating her brain. I mean, she did not do well. I mean, she survived and she's doing better now, but some of the patients, it's really, really hard. Now, in her case, the CNS lesions did show up and she needed the treatment. So I say it's probably a case by case because, well, yeah, it's 56 up to 90%, but it's not everybody. There's a percentage that won't have it. And if you are able to do careful monitoring, some people may not need the treatment after all. So I don't know. It's a difficult one. It's one of the ones that we know if we made the right decision after the fact. If you
Thank
see
you.
this like 2 years later, you look back and say, oh, that was a good call or not. Because, if you treat and they don't show up with CNS lesions, you think you prevented it, but you're not sure.
Okay, thank you.
Dr. Julia, can I ask one question?
Sure.
Yeah, Dr. Julia, most of the time we know that the biopsy report, even we get a good vitreous sample, as most of the time it's inconclusive if we don't have too much sample or the sample is not quick enough to reach the lab. My question is that even if the biopsy is inconclusive and the lesions are progressing, do we start methotrexate or we wait for the conclusive evidence and then we do a second biopsy or do other investigation, or we straight away start with the intravitreal methotrexate?
It really depends on the clinical presentation, right? For instance, that patient on the second eye, after we had all of those issues, I agreed to start the methotrexate even without a biopsy. But the first eye, because we really couldn't see anything that was glaring clinically, it's always very difficult. And I have had diagnostic vitrectomies that, I usually do the MTX at the end of the vitrectomy. That I did a vitrectomy, I put the MTX in, the result was inconclusive, and then the patient's like 20/20. And, do you keep going with the methotrexate or not? It's a case by case basis. It really depends. So if I have a really kind of thick vitreous and I do the vitrectomy, and then for any reason the vitrectomy result comes back negative, but I'm clinically convinced that it is, then I will get a special consent from the patient and I will treat it. But if it is a case where we're like, I'm not sure, it's not very convincing, and then the biopsy, the vitreous biopsy comes back inconclusive, then I don't do anything, I watch it.
Thank you.
I hope that helps.
Yeah, thank you.
Well, I'm glad the case has got some good discussion, and I guess it is a very challenging topic, and we don't have all the answers, but it's always good to bring it up. Thank you so much for this opportunity.
Thank you so much, ma'am, for that wonderful lecture. So, Kushal, I think we can, we'll go ahead with our next talk.
Yes, I think, is Dr. Abdullah is here?
I think he's not joining.
Okay, fine, then we can
He's
move
stuck
ahead.
in OR. So we just got information that he's still stuck in OR. So he won't be joining us. So I think we can go ahead with Dr. Vega's talk.
Yes, sure.
My turn? Hello.
Yes.
Good evening,
Hello.
ma'am.
Hi. Good evening, Dr. Vega.
Everybody.
Good evening,
Well,
Dr.
good
Vega.
morning, Brazil.
Oh.
Good evening. Good morning, Brazil. Good evening to you.
So
it's a very big...
it's my, yeah.
Oh, I'm sorry.
So it's my pleasure to welcome Dr. Francine Vega, an accomplished vitreoretinal surgeon from Brazil. Madam will be, excuse me. No? Yeah. So Madam has been deeply involved in clinical care, education, and professional training, especially in the field of surgical retina. And today she will be sharing her experience through a case-based discussion on endophthalmitis, a surgical approach, highlighting practical decision-making and management strategies for real-world practice. So we are very delighted to have you, ma'am, with us, and we are looking forward for your valuable insights. Over to you, ma'am.
Thank you so much. It's a very big pleasure to be here. I was here last year and it was amazing. And it's very, very nice to be with you. And I would like to thank Dr. Vagla for this invitation also. And I brought you 2 cases to discuss. Can you see my screen?
Yes,
yes.
ma'am.
Yes, okay, thank you. And so all the screen, it's all right? How do you see it? Just my screen or all the screen? Just the PowerPoint?
Entire thing. The entire thing.
Everything? Okay,
Yep.
I'm sorry. So let me do the other. So I don't know what's happening now. It's okay?
Yes, ma'am.
Yes, okay, thank you.
Yes.
So I'd like to talk about endophthalmitis, and as Dr. Sari asked me to show a few cases, and we have a limited time. I thought we could discuss about diagnostic and intervention timing, recognition of the signs and symptoms, and therapeutic approach. And here we should discuss about TAP, intravitreal antibiotics, and vitrectomy plus intravitreal antibiotics. And what do you do? Because we know that we have endophthalmitis studies group that define how to treat it, but sometimes we have very challenging cases. So I would like to point out this topic. So the use of dexamethasone, if you do use always, or when do you use intraocular lens explant, when do you prefer to do it, if you do it the first time or not, and when do you choose to finish the surgery with silicone oil or not. So I'm going to present two different cases here. And also I would like to discuss the surgical failure and the infection recurrence and option for treatment. So the first case is this female, 46 years old, and she was submitted to phaco emulsification for phaco refractive because she didn't want to use glasses anymore. I don't know if it's a normal situation there in India, but in Brazil, we saw it each day more and more. So she had pain and visual blurring 5 days after the surgery, and she was diagnosed with endophthalmitis. And at the same day, in another service, she had the intravitreal vancomycin. So 3 days after, the endophthalmitis had not gone away, and then she was submitted to a pars-plana vitrectomy and intravitreal antibiotics. And at that time, they used vancomycin, ceftazidime, and also dexamethasone. But then, unfortunately, she had the lens dislocated of the vitreous, and the endophthalmitis was not treated, and she was referred to our service to another surgery. So this is the video. And what we did, we extended the vitrectomy, and you can see that she had the infection there, all this collections, and the lens was dislocated to inferiorly, and then we aspirated, and we have to do it very in a delicate way, because if you are very aggressive, sometimes you can hurt the retina and make it bleed. And so we at this time we put perfluoron to protect the macula, and then we start releasing very carefully the lens from the base, and you see there's a lot of deposits around the lens. And after we release the lens, we put, I'm sorry. Oh, what happened here? Sorry. So we brought the lens to the anterior chamber, then we open the cornea and we explant this lens, suture the cornea, and then we aspirate the perfluor. We search for any kind of breaks, and then laser the retina. And we did not finish in this case with silicone oil, just with BSS, and we did the antibiotic injections again. And it evolved very well. The vision is 20/80 nowadays. And I would like to, do I stop here, or can we progress and then we discuss after?
Ma'am, we can continue, ma'am, and then we can discuss after the presentation.
Oh, okay. So I would like to point it out. I'd like to know if you do intracameral antibiotic at the end of cataract surgery or not, and everything that I said before. Remember that the incidence of endophthalmitis is slowing down in days, but recently we have this publication of BATE. That's this bilateral syndrome or transillumination iris that happens in a very acute way that may be associated to intracameral antibiotics. So I would like to know about it, but I think we have to remember that when we are using antibiotics, even if it's in the anterior chamber or the posterior chamber, we have to be very careful of the dilution, because we can have orb that is occlusive vasculitis because of the dilution of the medication. And we have to take all this, we have to take attention to all this point. If the incisions are sealed, if we did a very good asepsia of the eyelid and the eye with iodopovidin, and the follow-up, because here sometimes we see that doctors are seeing the patient at the same day and giving a week to follow up. So sometimes the things happen in this between. That's the point I would like to point it out here. And the second case is of another patient of another city that she had also endophthalmitis after phacoemulsification, and then she had light perception when she arrived, and she have hypopyon and a very dense vitreous that we could not see, but at the ultrasound we saw this dense opacities but no retinal detachment, and she had endophthalmitis. So the first approach was to do postplanar vitrectomy, vancomycin, ceftazidime, and dexamethasone, but she recurs with hypopyon again and vitreous opacity after 2 days. The second approach was to do another vitrectomy, IOL explantation, and also antibiotic again. But also again, she had the recurrence of the endophthalmitis, and based on all these publications about the group of Dr. Nakashizuka since 2015 that he's been using for some challenging case, povidone iodine, we thought that it could be a very good option to this case, because 3 surgery without resolution. So I put here some QR code if somebody wants to read about it. And recently in 2025, he published a retrospective analysis of 11 cases that they've been doing since 2017. And so we decided to try this iodopovidin injection. And what we do here is, you see that the eye is very, very, very inflamed. And here you saw that we have all this hypopyon in the anterior chamber. So what we did is to put the iodopovidin in the anterior chamber, and then we were taking off all this fibrin, and as we have no possibility to see the infusion at the posterior pole, we left the infusion at the anterior chamber, and we tried to clean the most that we could here. And here we are using the vitrectomy probe to take off all this material, and then we have at least exposure to try to go to the posterior pole, to this posterior segment, and here we put the trocars. And then what we did was to left the infusion at the anterior chamber, and you see that's very hard to see the vitreous cavity because of the cornea, and also because of all this component, all this infection here. But we try to clean the most that it could. We have this big plaque at the posterior pole, and so we were trying. And sometimes the best we can do is just to clean the vitreous and clean everything, and try to put some more antibiotics. And here, what we cannot show here is that we put the povidone also in the BSS. So we use the BSS to do an asepsia of the posterior segment as published. And here we finish with silicone oil, and we have to do the antibiotics at the end of surgery, even if you use the povidone. So this is the dilution that we use. And also if you do the injection into the posterior chamber, and also if you use in the BSS. And you have to change it every 15 minutes, the BSS, because the stability of the povidone is just for 15 minutes. This is based on the first study that they did, that they saw that more than 15 minutes, near 30 minutes, you don't have action anymore. So I think for challenging cases that you did more than 2 surgeries and you didn't resolve the case, povidone iodine may be a salvage therapy, and it's safe, and the studies shows that we don't have toxicity for the cornea, even to the retina. And we can point out if we should consider this just for the last resort, or could we integrate it early into the management, because it's very cheap and it's very easy to find in any surgical center, because sometimes depending on where you are, maybe you may not have the specific antibiotics to inject. And I would like to thank my team, and that's what I thought for today. Thank you.
Thank you so much, ma'am. These were indeed very challenging cases, especially the second one with so much of with nil visibility, but still you managed to do it. I have a few questions, ma'am, especially in the second case. Did you close it with silicone oil or just with intravitreal antibiotics and saline in the second case?
I choose silicone oil in the second case, yes,
Yeah,
because
why not?
yeah, because we don't have relevant papers about it, but it seems that with silicone oil, the microorganism doesn't grow, so it may be salvatore in some cases. And also, if you have phthisis, maybe you can stop the eye of going to a bad end, But that was the point, and also the antibiotics, yes.
Yes, ma'am. And just one more question. In a case of pseudophakic post-cataract surgery and ophthalmitis, what are your views on cutting the posterior capsule at the end of the surgery for better penetration of the antibiotics into the anterior chamber? Do you do it routinely, or is it just an option?
Well, I think that may be the reason that in the first case the lens had drop off, because maybe the person opened the posterior capsule, and then it was fragile and maybe it fell down. So what I do, if I don't have this very catarrhal eye, I try, and you don't have so much infection at the capsule, at the sac, the capsule sac, I try to maintain the lens, but I also talk to the patient that maybe we will have to do the surgery again and take off the lens and also the capsule. And then we will have to wait at least 6 months to do another implant or see how things goes. And I don't open the posterior chamber if the sac is intact, if the sac has no infection. And I only do the antibiotic injection. But if I have a contamination of the sac, so I prefer to take out everything out.
Okay, thank you, ma'am.
Thank you.
If anybody else has any questions.
So yeah, Dr. Vega, I have one question. So very interesting cases and very good surgeries. So I see that you are using ceftazidime routinely now, as recommended by EVS. But what we have seen that in our country, CEFTA has shown a lot of resistance.
That's
and
right.
especially in our center, we have shifted to piperacillin almost about 3 years ago for gram negative. Vanco is still good. So how is it in your country, the sensitivity for ceftazidime?
Well, we haven't seen any resistance for this. What we have is this case that are very challenging, and there are few cases, but most of it we can solve with ceftazidime plus vancomycin.
Okay.
Thank you for your question.
Thank you.
And what about phacoemulsification? Do you do phaco-refractive surgery there, or it's not the common sense?
We do go for refractive surgeries, ma'am. And endophthalmitis is one of those conditions which will be there in any intraocular intervention that we do. So yes, there are cases And yes, the way that you have managed it here, especially, is very commendable. And thank you for showing us that video also. And I hope that answers your question.
Thank you.
Can we move on to the next speaker, sir?
Yes. I think Rushil has joined
Yeah,
in.
yeah. So it is my pleasure to introduce Dr. Eleonora Lavak, who is a prolific vitreoretinal surgeon from Argentina. She is currently at the St. Lucia Ophthalmologic Hospital, and she will be talking to us about a case of how to approach a case of metallic intraocular foreign body, which can often spell hidden trouble. So we are eager to learn from your immense experience, ma'am. So without further ado, over to you.
Thank you very much. So, are you seeing my presentation?
Not yet, ma'am.
Let's see right now.
Yeah.
Yes, you are. Okay. So let's see if it's big enough.
Not yet full screen, ma'am.
Yes. Okay, let's see.
I think the play button in the center, yes, on that one.
This will make it moves. I think I will try to at least. Okay. So, let's see. Like this. Okay. So today my presentation is a short one to show you my experience with these two cases. Intraocular foreign body is one of our routine cases in our practice if you are a VR surgeon. Here I show you the pre-exam of this patient where you see the hemorrhagic tract pointing where the intraocular foreign body is, and you see some vasculitis probably from infection that is coming on with this metallic foreign body. I've been doing surgery for many years, so I came in with surgery in this patient just to take the foreign body out. I want to show you up in right the CT scan where it was the metallic. So when I entered to the surgery, I take all the blood out, but I couldn't found this big intraocular foreign body that it was in the eye. So I want to see, before we go to the post image of this patient, how is the coronal cut, where you may see it like intraocularly, and you see in the right scan, the axial one, that you see that is in the eye wall, and you see a big image of what you suppose it is the foreign body. So when I came in surgery, I cleaned everything, and I knew I was supposed to look there where you see the scar, the foreign body. So I tried to dig a little in the tissue, but I couldn't see. I didn't have the control to see the foreign body. So this case has like 17 years old. And I start wondering why, if at the image in the tomographic cut I could see it, I couldn't see it intraoperatively. It's something rare. We usually find them quite easily and we take them out as soon as we see them. So I started thinking about the metrics. The sclera is really 1 millimeter, choroid is 0.2, retina 0.2, and in total, the three layers are 1.5 millimeter. So I started wondering about size of the intraocular foreign body. So then I make an X-ray of the patient, and I still saw the foreign body in the postoperative follow-up, and this was my scenario. I was supposed to take the foreign body out, that is the routine and the object of the surgery, but I stopped at the moment that I thought that I could make more damage, while mechanical injury during surgery, trying to dig in the tissue, Or maybe I start supposing that the foreign body may be stuck in the sclera, and I start wondering if I dig more, if I take it out, if I wouldn't have hypotony. But this was only one case of many, many, many foreign body that I take out. So I say, okay, I will start taking in account the metrics and seeing what has happened with this patient. Then this second patient came last year. And also I was at the OR, said, foreign body, you will see the track of blood, come, okay, we put it in the row, you operate. So I entered to the surgery. It was also an eye wall, foreign body, and I found the same. I couldn't saw the foreign body, because if I saw, I take it like we are used to do in surgery. But here I have hemorrhage, retina edema. I start digging a little in the tissue, but I couldn't find it. So in this second case, I still wonder, so I make a tomographic cut after surgery, you see, well, my surgery, and you see the foreign body in the eye wall. So, and also you see backwards from the sclera, you see an air bubble. So my decision here was not to take it out, because I have to do some mechanical digging in order to take this eye wall for each body. So this is the evolution of the patient. He made a scar, he has a beautiful vision because macula wasn't compromised. So what I want everybody to take from at least my two cases and my experience with the eye wall foreign body, that there is a dissociation of what you see in the tomography or what you find intraoperatively or what you can find with the radiography. So X-ray may show you the correct size that tomography doesn't show you, and tomography may show you a closer approach to the location, but not exact location. So there is a dissociation. So whenever you have an eye wall metallic foreign body, you have to take these considerations into account. So for taking you some pitfalls about this, sometimes doing the best, maybe to leave your proud inside or swallow your proud and have to leave the foreign body in order not to damage, but with some thoughts in that respect. You know that when there is an eye wall intraocular foreign body, may be a radiological dissociation that you won't find out till you are inside the surgery. So please take into account this, that you have a mechanical damage that you can do if you start digging in the tissue versus a chemical one if the patient develops siderosis, which can, of course, he can develop, but is more prompt to develop it if it is close to the liquefaction of, or the liquefaction of the vitreous, and is less probably if it is buried in tissue, because it's not as exposed as fluid as it is when it is in cavity. Thank you to some case reports all over the world. We know now that if they are small enough, they may reabsorb, even though they are metallic, or they encapsulate, preventing siderosis. We can still have a secure follow-up, of course, with visual acuity, but also with electroretinograms. And what we know of that if we have a patient with a retained foreign body that is developing siderosis in the follow-up, the patient can take the decision to make a more delicate or hurtful or invasive surgery, because when we take the intraocular foreign body out, we can do the siderosis to reverse. So these are the concepts that I would love to to share with you, in my experience with this type of metallic foreign body of the eye wall, specifically the little ones, that doesn't has nothing to do what TC scans shows about size, because it is like magnified the size of the foreign body. Thank you.
This is a very, very interesting talk, ma'am. Funnily enough, I am dealing with exactly a similar patient whose CT scan is very similar to the CT scans you have shown in this particular slide. And I was actually going to ask you how to approach this patient because he has a history of foreign injury 10 years back. And now he has a dense fibrosis and the foreign body is encapsulated. But my problem is that he has already started developing signs of siderosis. And he has a good vision of 20 by 80. So now my question is, should I attempt to remove it with the risk of having a permanent defect in the eye wall, in the sclera, possibly, or should I just leave it and follow up serially on ERG, like you say?
Okay, but siderosis is developing, you tell
Yeah,
me.
yeah. It's already
Yes.
started. Yeah.
Okay, the patient may take the decision to, before we were like a paternalistic decision-making process where the physician took the decision for the patient. Right now, I prefer the other approach when I tell the patient the two options and the decision is from the patient, not from us, making a balance. So, but if you decide with him that you are going to take the intraocular foreign body that I think you should, but if you are deciding, I may have a day out or sclera in order to put a plug in case it is stuck and when you take it out, you lose intraocular pressure and also heavy bleeding. So I will do a round heavy diathermy before taking out the tissue, looking for the intraocular foreign body. Also, you have to do it slowly if you may have the opportunity to see the foreign body, because you have to expect they are really little and they may come in the mouth of your vitrectomy. So in order to you to be completely conscious that you're taking it out, because if they are small, they may come through the port of the vitrectomy without you noticing it. I mean.
Yeah.
So, Dr. Eleonora, one question I had. So, did you try using the magnet over the lesions during surgery?
I did, because I have the one that is the portable magnetic, and I have the other that is like a LED electrical magnetic that is really powerful. But what happens is that you need a size of metallic intraocular foreign body to be attracted. So if it is really small, it doesn't have the size enough to be attracted, and you have to go really close to the retina. I have the two types. One that is longer that you can go close, but is weaker, and I have the other that is electric, that is powerful, but I have to stand at the sclera port in order to activate it. But it didn't came to the port of. Yes, I try everything. Besides, I didn't want to dig enough. Yes.
Dr. Eleonora, very nice presentation and very, very interesting foreign bodies.
Yes.
I just want to ask, when you went ahead with the vitrectomy for the first case, how long the trauma was before? And when the surgery was taken, what was the duration of symptoms?
Always short, because when you leave the foreign body more than 24 hours, like 48 or 20, you raise so much the probability of endophthalmitis. So it arrived, we start running and seeing how far we can, and it was quick. Otherwise, also it encapsulates and make your life difficult.
That's what I wanted to ask, because if there's an encapsulation, sometimes the magnet will not attract the foreign body. And
Of
those
course.
cases, normally we just peel the capsule with the MVR blade or any sharp blade, and then the foreign bodies generally, which normally are not visible, can be taken out. but luckily I didn't have any issue as such. But there are very, very interesting cases that you're not able to see any foreign bodies in spite of very clear-cut sign of foreign bodies on CT scan. So very interesting.
Yes,
Also, Dr.
yes,
Eleonora, one point I had. Yeah,
yes.
so I think the lesions were very close. You could have done OCT also over them. I think in
I
the
could.
second case, it was nasal to the disc just inferiorly, or even in the first case also, you could have passed the OCT scans over them.
Yes, yes, I did. But in the second case, there was a fibrosis that cut the scan to go through the tissue. I wanted to see it, but I couldn't because fibrosis didn't allow the scan to go in.
Yeah,
It's a good,
yeah.
I tried to, edema, hemorrhage, or fibrosis doesn't let the
True.
light of
True.
laser to scan there. Yes.
True. But both were very interesting cases.
Yes, it's for everybody to have into account because we are really want to help. We go inside and we found out this intraoperatively. So I hope you have it in mind because I do. After my first case, I have it in mind. I say it cannot happen to me again. But when you
Yeah.
operate a lot and many years has passed, the cases start repeating. That is what is so interesting, even though they may just be a case report, that everybody reports them because I mean, it's not a huge quantity of evidence, I know, but there are some rare cases that is really worth it. So I support this with these rare cases that reabsorb or siderosis that were reversible. So we need all this experience published.
I think Rushil's case also further signifies that it took almost 10 years. He's saying that patient had injury almost 10 years ago. So that
Yeah.
further puts across this point that you can actually wait in such cases. And sidrosis has taken almost 10 years, and then only there is mild sidrosis. So I think we can wait. Yeah. So that is a
No,
lesson from Rushil's case.
I
Yes,
tend
it
to
has.
disagree. Yeah, I think we should not wait. When the foreign body is there and you have already documented, you should not wait. You should go out and take the foreign body as far as possible and as quickly as possible. Because once the sidrosis start, even the vision is 20 by 18 Rushil case, but now the sidrosis is irreversible. Even if you remove the foreign body, sidrosis is going to set in and the patient is eventually going to lose vision. So if you
Yes,
have
I think.
chance, go in early, remove if you have the chance. Otherwise, you'll lose the eye in
Yes,
this
I would
procedure.
love to be as secure as you are, but I fear about intraocular pressure going down. If it is stuck in the sclera, yeah, and I may lose the eye. So I like to be, I would love to be all secure. I go and take it out. Yes, for me it would be really easy to cut everything with a vitreous cutter. But as I told you, you are proud, you have to swallow and try to resist the impulse to take them out because you can do more damage is what I think right now. But yes, you are right also that siderosis may develop like 10, 20 or 30 years later and you make an slave your patient because he has to come. But it's a decision that he can take also. If he wants to risk this, he can risk. But if the intraocular foreign, because you don't know the size, you see the CT scan it looks like big, but that eye wall is 1.5 and that image is magnified. One thing, see the CT scan and you say, okay, it's really that big. I am going to take it and take it out. And with the magnification we have. But ILM is really as little as a few microns, and we can take it out so easily, but we see it. When you don't see it, it's more difficult. And as I told you, this is really a little foreign body. So I still wonder what is the best decision. And sometimes not doing it is hardest than doing it. For me, would be in more peace if I take it out and I just live in peace, not thinking about siderosis development.
Can I have a little comment on this presentation?
Also, of course.
Yeah, this is Sharif Sheta from Egypt. Nice work. I have an experience with a posterior defect in the global ward by removing a posterior encapsulated foreign body. And in this case, it's forbidden to use perfluorocarbon liquids because one case I used perfluorocarbon naively and it escaped into the orbital cavity.
Okay.
And so in these cases, avoid as much as you can to do much manipulations. Hypotony is a problem, but I have a clue to close this posterior perforation in my presentation. And thank you.
Thank you. Okay. Thank you. I would like to see that. Thank you, everybody, for your attention and your questions. Okay.
Rishil, should we move on?
Yeah, over
Yeah.
to you. Raj.
Okay, so it's my pleasure to welcome our next speaker, Dr. Sharif Shetta from um, he's a professor of ophthalmology and veterinary consultant at Cairo University and chairman of Dar El Ayun Eye Hospitals and Centers. And today he will be speaking on yet another interesting topic on Tenon's capsule graft for reopened macular hole. Over to you, Dr. Shetta.
Thank you very much for inviting me to this world-class webinar with a huge number of expert vitreoretinal surgeons and large audience. So the topic of my presentation, I hope it's visible.
Yes, it will.
Yeah, the topic of my presentation is to use Tenon's capsule graft for reopened macular holes, which I think is a handy solution for a difficult problem. You know that since the work of Willie and Kendall in the 90s, the macular hole surgery have been one of the most successful surgeries with closure rate of more than 90% with different techniques. So they tend to close, these holes tend to close. But there is a subset of patients in which the hole fails to close. And we have many options. We have a large menu to choose from. Even you can do revision of vitrectomy with long-acting gas injection, revision of vitrectomy with retinal massage, a revision of vitrectomy with a viscous material like platelet-rich plasma, or revision of vitrectomy with induction of central detachment to lyse the adhesions that prevent the closure of the macular holes, or use residual eyelid flaps if available, lens capsule flaps, Decimus membrane flaps, amniotic membrane patch, autologous retinal transplants. All these are options, but what I'm supposing or proposing today is to use the Tenon's capsule graft for these cases. In the last Euretina meeting in Paris just a few months ago, there was a survey about what is the most commonly used technique for closure of open macular holes. And definitely eyelid flaps, if available, are very popular, more than 50%. Then amniotic membrane graft, later with the autologous retinal transplant, subretinal injection of fluid, or platelet-rich plasma. And some people say that they don't do anything for this case. I think reclosure of these holes are doable, and we can close these reopened macular holes. I'm going to present few cases. This is a case that was operated several years ago for macular hole, and the macular hole failed to close, and she came only due to displacement or posterior dislocation of the lens. And she had several vitreoretinal surgeries before for retinal detachment, peripheral breaks, and a large macular holes. We have to remove the displaced ILM, and then we inject a Tenon's capsule graft, which is ready-made from the superior limbic area. And you can see that this material tends to stick to the macular hole area because it is sticky. You can fashion the size of the Tenon capsule graft to be as large as the macular hole. You don't have to make it much larger because actually it tends to stick to the macular holes. If you have a small amount of bleeding, that's okay. And usually after fluid exchange, I put some visco material just to stabilize the flap. And I ask the patient to stay on his back for like 1 hour so that this flap will stick on its place before adopting the face down or posturing. And this is the result with the gas bubble still in the eye, just like 10 days after the surgery. And you can see that in spite that the gas bubble went smaller, yet the hole is closed and the flap is still in place. And this is the beauty of this flap. You can see this Tennant's capsule flap just fitting into the large macular hole like a bolus. Because it fits into a large hole, it tends to stick to the underlying retinal pigment epithelium, and it's a perfect stuff. So I think in these cases, using amniotic membrane, using Tennant's capsule flap is a feasible option. This is another case with a traumatic macular hole in which I did primary surgery with ILM flaps as usual. And in this case, I used like a rexes to fashion the flap. And I did a hinged flap of the ILM to close the macular hole. And you can see here, this is a large macular hole. And I used a hinged flap, just fashion the flap and put it over the macular hole and did fluid exchange, hopefully for the macular hole to close. And this is after 1 month, the patient came again with reopened macular hole. Because I have done the primary surgery, I went again for the second surgery and I did a stain, and I find that the island flap or the hinged flap have moved. And you can see recatching the island flap and repositioning it again over the macular hole, hopefully that this will plug or close the hole. And I did enlargement of the edge of the flap, put some visco, and enlarged the flap and put another hinged layer of ILM to close over the free flap. So now they have two flaps of ILM inside the macular hole. In spite of that, the hole failed to close and the patient came again. I restained and I found that even the second flap have moved away. And you will see in shortly that I can manipulate and move this flap again and put it over back of the macular hole. And you can see here, this is a displaced flap. So I mobilize the flap, put it again over the macular hole, but in this time, for the third time, I wanted something to secure the flap in place. So I added a Tennant's capsule graft over the island flap because the stickiness of the Tennant's capsule will allow this island flap to stick again. You take a small piece, you spread it over the corneal surface, you make it as smooth and as transparent as possible, and then put it again. You can see here, I can trim the large so that I fashion very low cutting rate so that I fashion the island flap over the hinged island flap. And this is the surgery after surgery. The hole closed. You can see that the flap is very faint and the hole actually has closed. And you can see here in the OCT that this is the Tennant's capsule flap, and behind it is the island flap. And you can see there is starting regeneration of the outer retinal layers and the vision of the patient actually improved. So you can even combine the Tennant's capsule graft with a small island flap to secure it in place. This is the large and the third and the largest macular hole, more than 2,000 micron size, and the patient have been there, this hole, for years. And she came also for the displacement of posterior dislocation of the lens, and she felt something went wrong. I proposed for the patient that I can remove the dislocated IOL, but we can give a chance by closing this macular hole. Here you can see the displaced in the bag IOL, and she had several vitreoretinal surgeries. I mobilized the dislocated IOL into the anterior chamber, make a corneal incision, removed, and close the corneal incision, put an anterior chamber IOL because the patient was old and there is no risk of inducing corneal decompensation by this, because I think this is the safest and the easiest way to rehabilitate the IOL. And then put a flap of ILM into the macular region of the Tennant's capsule. And this is the post-operative picture. You can see the flap closing the macular hole. And this is 1 month after surgery. You can see the Tennant's capsule flap like a hinge here. But if you look closely in a 3-month OCT, you can see the flap have actually disappeared, and you start to see regeneration of the retinal layers and the visual improvement in spite of the huge size of the macular hole. This is a pre-operative and post-operative picture. You can compare the retinal hole. It's very thin, and you can see that not only the hole have closed, but the retinal thickness increased. I wonder if this tenon capsule contain some promoting cells that promote healing and improve nourishment of this thick retina. So in brief, I think that Temen's capsule frap have several advantages. It is readily available, it is cheap, it is autologous, and it is sticky, and it may promote healing. And in these cases, there is no need for gas tamponade or long time of posturing. In all my cases, I've used only air, and the posture is only few days, like 5 hours daily for 3 days. And I've used the tenon capsule graft actually for other indications. I have used it for optic pit maculopathy. So I can stuff the optic pit with a tenon's capsule graft, which is a perfect match to close the optic pit. I also use the tenon's capsule graft to close posterior perforation site, as we have previously discussed. Because this is available, you can fashion the size whatever you have, and it sticks and it closes and may promote healing. So I think Tenon's capsule graft should be revisited in these special cases. And thank you for inviting me.
Thank you so much, Dr. Seta, for this excellent presentation. You made it look so simple, and it's actually you showed it's so much effective in even regenerating retinal tissue in certain areas. So my first question will be, do you see any change in the size of these grafts that you place over time? Because even in retinal tissues that we put autologous retinal transplant, we see some shrinking over time. What is your experience with these grafts?
I've done all types of treatments for EOPID. I have used ARTs, I have used amniotic membrane grafts. I think ART is very traumatic, especially in attached retinas, and I don't believe much in the reconnection of the neural elements. So I think it's primarily a plug. So if you have another plug that is readily available without cutting the retina, and actually it doesn't shrink. It becomes fainter, so you don't notice the partially white color with time. It gets fainter, and actually it's still in place because it sticks. So I think this is a good option to consider.
Thank you, Dr. Shweta. We have a question in the chat box by Dr. Vega that is there any risk of PVR formation in these cases?
Excuse me?
Is there any risk of PVR formation
No,
in these cases?
no, not at all.
I have a question.
These eyes are already vitrectomized. So all these cases already have several vitreoretinal surgeries before they are vitrectomized, and the retina is very quiet. So there is no risk of PVR formation actually.
I have a question, sir. It's a wonderful surgery and the results are very gratifying. We have used amniotic membrane, anterior capsule, and all kind of grafts also. My question is that how are your post-op visual results? Because what mainly we want to see is that how much improvement patients have. Whether we need to counsel them aggressively once we know that we can close the hole. But is there any visual gain after the surgery?
100%. Actually, the last case with the size like more than 2000 micron, I was very skeptical that it will have any improvement of vision. And actually, the vision is 660, and she is impressed, and she started to read. And this is amazing because if you see the OCT pictures before, you can see organization of the outer retinal layers. And I wonder why. I wonder if this is only a plug or that is the fibroblast or the promoting cells in this promotes healing and invites cells to migrate and repopulate the area.
There's just one more question. And how do you get the Tenon's capsule graft? I mean, do you cut yourself or how
Yes.
do you get it?
You make a limbal incision and immediately a limbal incision, and you just reflect the conjunctiva and take a small piece of tenon. I spread it over the corneal surface, so I want to be as thin as possible.
And do you take a part of a limbus stem cells also include
Yes,
in that?
yes. So I make it very limble so that it includes cells that can promote healing. And I spread it over the surface of the cornea, put some BSS drops so that I know that it is, and I can trim it. because you don't actually need to have a large piece of Tenon's capsule. And if I spread it on the surface of the cornea and I can see the cornea through it, I think this is the ideal, because it is a thin membrane that fills the gap and without making too much fibroblast that can promote fibrosis. So in all these cases, the flap did not shrink and it did not move away and it sticks to its place. And in some of the cases, the visual improvement was remarkable.
Thank you.
We have another question in the chat box. For pit maculopathy, what do you prefer, scleral patch or Tenon's patch graft?
Actually, I was using in optic maculopathy, I used everything. I used the island flaps. I usually make two flaps. One flap, I make a fovea sparing island flap, and I make another flap which is large and reflected over the optic pit. But once I started to use the Tenon's capsule flap, I think the Tenon's is more logic because the island flap is so thin and it does not stuff inside the macular hole. But I used punctum plugs before. I used the scleral, resected part of the scleral wedge to insert. But I think the beauty of the tenon that it modulates itself into the plug, into the pit, and it fits in the pit. The problem with the optic nerve biplopy is that you don't have a large number of cases to make a control study to think which one of them is better.
Thank you, Dr.
Dr.
Sharif. I
Sharif,
think
a very yeah, Dr. Sharif, it's a very innovative idea. In fact, to use tenons as a graph. My question is, like previously, Dr. Kapil also asked, it's a very thick tissue. So, how many cases you were able to visualize that there was a potential gain in the vision in these cases? Because considering the thickness of the tissue, there are very high chances the vision might not improve in these cases.
So you are speaking about the post-operative visual improvement?
Yes, yes, yes.
Actually, I've done 12 cases. And among the 12 cases, 10 cases experienced improvement in vision. And the visual improvement varied from 160 to 660. So the best vision I had is 660. Most of them had vision like counting fingers or hand motion before. So in two cases, there have been no improvement in vision, but the patient felt better, probably because he started to see extrafoveal, because there is some sort of fluid or detachment around the macular hole, and once this is plugged, he can see extrafoveal better with extra fixation. So in 10 of the 12 cases, there have been a considerable improvement of vision. In two cases, the vision was not changed, but the patient
And
felt better.
one more question is like when we are using a graft in macular hole, the major concern is the dislodgement. It might not stay over there. Like you earlier used the ILM flap and it was not staying over there. What could be the reason why you think that Tenon's capsule was able to stuck over there and you were able to put it just by air and with the
You know, when you try a procedure 2 or 3 times and you don't get a good outcome, so you don't have to try it again. So I thought that adding a Tenon's capsule flap over the island flap will help stabilize this flap and maybe promote more healing. And actually, this patient, one of the most improvement in vision happened in this patient in combination of the island flap, and probably he was younger and probably has a better circulation. And the other two ladies that I showed with posterior dislocation of the IOLs, they were old, like in the 70s. So this patient with traumatic macular holes were like in the 40s, and he get the best visual improvement.
okay. Thank you once again, Dr. Sharif, for sharing your time, experience, and insights with us. So I'm sure many of us will start using this technique for our future surgeries. So with that, I'll hand over the session to my next co-moderator. Hardik, can we move on?
Yeah.
Thank you very
Thank you,
much.
Niraj. Thank you.
Thank
An
you.
excellent
Thank you.
presentation. Yes. So, good evening, everyone. It gives me great pleasure to introduce Dr. Andreas Di Luciano, a renowned ophthalmologist and vitreoretina surgeon from Chile. He is known for his work in Orbis International and his expertise in retina and simulation-based surgical training. Today, Dr. Di Luciano will be sharing his insights on fascinating and important topic of black swans among the complications associated with silicone oil use. Over to you, sir.
Thank you so much for the invitation. It's an honor to be here among you guys. Tell me if you can see my presentation.
Yes, sir, we can.
Okay, it's okay.
It's well visible and you are well audible. Yes, sir.
Okay, so thank you so much. An honor to be among you guys. So today we're going to talk about black swans among complications associated with silicone oil use. So before we start, we need to understand the definition of what is a white swan and where I took this concept. So I took this concept for a nice book called The Black Swan from Nassim Taleb. And from a statistic point of view, a white swan is a predictable event with a moderate high impact within, and this is very important, within that was expected. So just keep this concept in mind, and then we will develop it through the lecture. So what we already know, we did a systematic review a few years ago to regards all the complications associated with the silicone oil use. We do a systematic review without a meta-analysis because it was so difficult to measure all the data because it's super heterogeneous. Most of the papers that we review were retrospective with a 2 level of evidence. We took in consideration all the most important things from a statistic point of view that you should take in consideration when you're doing this kind of studies: demographics, time, type of silicone oil, follow-up, etc. We measure the media, we measure, of course, the interquartile range, and generally speaking, we found a high variability but similar frequency for the most common ones. And when we're talking about the white swans is what we already know. We know to regards the cataracts, we know that the cataracts are one of the most common complications secondary to silicone oil use. We know that almost 100% of these patients we have at 5 years cataracts directly related of the duration of the silicone oil, and because there is an alteration of the crystalline lens in the epithelial cells because of the contact of the silicone oil in that vector. We know that AC emulsification is a common one as well. We know that it's more common in 1,000 than if we compare it with the 5,000. We know the intraocular hypertension is frequent. We know that the glaucoma as well. We know that almost the 7% of this patient may require a filter and surgery because of the IOP control. We know that the ice emulsification, the glaucoma, and the hypertension can be combined with a pupillary block, or can be happen because of the chronic inflammation or obstruction of the trabecular meshwork, or for anterior-posterior synechias. And we know already this. We know already that we have the retinal detachment. We know that the most common cause of failure on the retinal detachment surgery because of the PVR. We can have hypotony, we can have ciliary ganglion dysfunction, subretinal migration, keratopathy, and of course, one of the most common ones and the less more understood ones as the unexplained visual loss. So we know this already, right? So let's talk about, but we don't know too much. Let's talk about the black swans. And what is the definition of what's a black swan? So before that, we have to define what is considered a very rare, very rare species. And for this, if we take in consideration a concept from the European Union, from the US, and from Japan, we will define this condition and any pathology with less than 0.04% of frequency, like super rare condition. So now we are able to talk about black swans. And what is a black swan? Black swan is a highly improbable event, but with a great impact. And this is important. I will show you some examples of black swans in real life. For example, when happened this, nobody expected. Was super, super, super rare. But when happens, the consequence, the impact globally was unbelievable. The same happened when we have the COVID. Nobody was expected this. But when happened, the impact was, and the consequences were globally. And the same, for example, if we have a downturn or any economical recession, we are not prepared to this. But when it happens, the impact is enormous. So there is any complication that we study with a group of retina surgeons that we like to do we like to do systematic review. We like to review things that for us are very uncommon, and we found that there is a very rare complications to regard silicone oil use called cerebral silicone oil migration. And when we study this from a statistic point of view, we found that this pathology, if we compare it with the other ones, has a high variant coefficient interquartile. And what means this high number of CVIQ? This indicates high uncertainty in stemming frequency. So this makes that this disease a very rare and difficult to study complication. And also it's difficult because we have a low predictability. But the problem is that this complication can have serious consequences. So the intracanal migration of silicone oil can occur everywhere through the optic nerve, through the optic tract to the brain. So it can be, or we can find silicone oil in supranuclear space, in the ventricular system, in the optic chiasma, and also in the subdural region. They are the most common areas that we found in our study that the silicone oil was founded. And the hypothesis to regard this pathology is that this increase in the IOP overcomes the pressure of the lamina cribosa. And that's why in this patient, for example, because the risk factor that were considered to this pathology was the previous glaucoma, or patients with optic neuropathy, or patients with an optic nerve anomaly. And all this patient has has something anatomical that that makes easier to the silicone oil to move from the optic nerve to the optic tract to the brain. And these are the most common risk factor: increased IOP, optic nerve degenerations, and optic nerve anomalies. So most of the cases, thanks God, are asymptomatics and are usually found in imaging. For example, if we see retrospectively which are those patients that we found silicone oil in in random events, are patients with complex chronic retinal detachment with multiple surgeries and long-chain tamponates. And of course, this benign course with no surgical sequelae. But the problem is when we have patients symptomatics with silicone oil migration. That's the problem. That's the group of patients that we should be aware. So what we found? So we found that most of these patients, when we found silicone oil in the brain, were patients with a chronic or complex retinal detachment, secondary, for example, to trauma, or secondary to a proliferative diabetic retinopathy. We found that most of the patients had 5,000 silicone oil chosen as a tamponade. Some of these patients had glaucoma, and the time of tamponade, or the time that the silicone was inside the cavity, was between 15 months to almost 20 years. So it's a long chain of tamponade. So which one were the most common sites of migration of the silicone oil? So we found more of this in the ventricular system, in the optic chiasma, and also in the subarachnoid space. As you can see, the symptoms are very ample. So there is a lot of different ways to manifest this information in the patients. So we found that the most of the cases, and this is also why we don't know too much about this pathology, is because one of the cases were reported in radiology or neurology journals. So maybe sometimes the ophthalmology even never know that this happened to these patients. So most of these patients were complex retinal detachment. This patient had secondary glaucoma or was a medical history of a previous optic nerve anomaly or optic nerve pit. This patient had long tamponade duration between 15 months to 20 years. The most common symptoms were super inspecific, like headache, dizziness, loss of consciousness, nausea or paresthesias. and very important because some of these patients were in a differential diagnosis between neoplasia or some very like super complicated pathologies as a subarachnoid or intraventricular hemorrhage. So some of these patients also had treatment because they thought that there was a hemorrhage when was not a hemorrhage, was a siliconoid migration in the brain. And of course, there is complications reported as chemical meningitis, elliptic seizures, hydrocephalus, or any sensory or motor deficit, specifically where the siliconoid was doing compression or damage. So as you can see, if we try to make a difference to regards the characteristic of the features in imagenology, you will see that the characteristics of this pathology is super random. So there is super inspecific. There is not like one image that you will say, okay, this image is compatible with siliconoid migration. And this is why it's so difficult to the neurologists or another doctors to make the difference between if there is a siliconoid in the particular system or can be something more serious as an intraventricular hemorrhage. So that's the siliconoid migration. And we have also another black swans that maybe is underreported as, for example, intraocular siliconomas, because it's the process from emulsification to encapsulation to the formation of the granuloma. And this has a wide clinical spectrum. We can see as a chronic uveitis, as an extraocular muscular restriction, ptosis, proptosis, etc. And of course, there is supported and other cases in the literature to regards, for example, arterial obstruction due to silicone oil with, of course, serious complications in the vision of these patients. And also explosive hemorrhage or pigmentary or retinopathy like vasculitis, etc., etc., etc. So the most frequent complications are mostly predictable and preventable, and we know it. Demulsification is inevitable and it should be considered at a warning sign. Less frequent complications, as for example, siliconoid migration, siliconomas, hemorrhage explosion, are not random. They are often underdiagnosed. And statistics often show us what clinical practice cannot see. And Black Swan, that's the message to take home. Black Swan exists, and we cannot always beat the statistics. So thank you so much for your attention.
Thank you so much, Doctor. I think excellent presentation, and thank you for enlightening a very rare topic. I think very few of us are having the knowledge of this intracranial migration of the silicon oil. So we are open to have questions. First of all, I would like to have a question, Doctor. So in every post-op cases, we don't do this MRI or CT scan images. So usually in which cases, like for how many days or how many months later the patient develop this such the symptoms of the like headache or whatever symptoms we have discussed, how many days it can take after surgery?
Yeah, for example, if I show you this, because these are the charts of our study. So here you can see that the symptom in the patient that had symptom started with a tamponade a time of 15 months. That was the short one. And the long one was 20 years. So it's super specific. We don't know when this happened, and we don't know when to send this patient sometimes to a neurology, because when a patient has a headache and you had the surgery time ago, you can see maybe the headache is from another neurological disease, and sometimes you don't associate this neurological symptom with something that you did time ago, because sometimes the surgery was 2 years ago. Sometimes the patient has a normal IOP, but the silicone already migrate to the brain. So it's super difficult to decide when to suspect this pathology or when to send it to a patient. For example, what I do normally in patients with chronic retinal detachment or very complex one, after 1 year, with the silicone oil, if I didn't remove it or change it for another one, I send this patient to a neurology. I send the patient, all the patients, 1 year with silicone oil, I send them with an order to do an image. Can be a CT scan, whatever, but I send it always because after we did this study, we were more aware of this very rare complication.
We have a question in our chat box that how do the neurosurgeons handle these symptomatic cases? Can they remove the silicone oil?
If you remove the silicone oil, the symptoms will not go away because the silicone oil is already emulsificated in the brain. So most of the treatment of this patient were more conservative, like wait, observation. I didn't found any of these patients were under surgery, maybe to remove this like a mass, like this silicone tumor. I didn't find any of these patients were under surgery. But very important is that two of these patients were treated as they had another pathology. For example, two of these patients were suspected to have a subarachnoid hemorrhage. And of course, when you see this, your act of action is urgently. So they did a treatment and they found that was not an hemorrhage, it was a silicone oil. So they, of course, in that case, they removed what we found. But this can also bring very like complicated medical legal things if we do a treatment and we are not sure that is that the condition. So it's a very, very difficult, thanks God, super rare condition, but it's there. And sometimes we don't know, but may we have some patients in other country, in other city with the silicone oil maybe migrated to the brain and we don't know.
Yeah. Thanks a lot. If we don't have any question, I think we can go ahead with
Very
our next
interesting talk,
presenters.
sir. I just have one question. So, what do you think is the pathogenesis? It is actually going and blocking the outflow somewhere. So, will putting a drainage shunt in the brain, or is it the raised ICT which is actually causing the headache to the patient because of it is blocking the channel? Somewhere CSF flow is blocked because of the silicone oil.
You mean like a like a shunt, but from neurological point of view? You mean that?
Yeah. So, what is the pathogenesis for the headache? The oil has gone. It has gone through the optic nerve, maybe probably from the sheath, and it is probably through the CSF. It has reached the brain. So, is it causing the outflow to be blocked
I
of the
think it's a
CSF?
combined. I think it's a combined things because most of the patient has already glaucoma, so probably it is also secondary glaucoma that also can explain kind of the headache, and of course probably one of the compression sites of any of the nerve that there is the brain can maybe explain this. As I told you, we didn't find any like surgical treatment to the pain of these patients. Only in 2 cases, this patient went on the surgery because they thought that there was a subarachnoid hemorrhage. But it's a good question, and I don't have the answer right now.
Thanks. Great observation. In fact, what we'll say.
Thank you, doctor.
Thank you, my friend.
Yeah, a very interesting topic you brought because as I can see in the cases which you have shown, that most of the cases were there when we left the silicone for a long time and there was extensive emulsification. So probably one take-home point might be that we should not be leaving if there is a extensive emulsification, it's better to remove the oil. So the chances of migration are less. And another thing is, I think most of the time the trauma cases when we might have a double perforating injury is somewhere else or the optic nerve pit, there is chances of migrations are very high.
Yeah, definitely. Yeah, good feedback. Yeah.
Actually, Dr. Lockwood would be joining. Dr. Lockwood will be joining a bit later. I think we can move to the next session.
Thank you so much, guys.
Thank you so much.
Thank you.
The speaker is not there.
No, Dr. Lockwood is going to join a bit later, so I think we can move to the next session.
So we can go for the next session, right?
Yeah, I think he might join later, so maybe at the end we can take his talk.
So we'll move to the next session. I'm Dr. Sharath Hegde. I'm a vitreoretinal surgeon in Udupi. So I'll be moderating the first talk of the VR maze, navigating unexpected obstacles in surgery. For this, we request Dr. Mohsen Abu Sosha to give his topic, titanium macular buccal in myopic traction maculopathy. So Dr. Mohsen is a very pleasure to introduce him as a distinguished vitreoretinal specialist, and he is a lecturer in the Department of Ophthalmology at Alexandria University, Egypt. So he has published many advanced retinal, many publications on retinal imaging, which includes like OCT and retinal nerve fiber layers in the Egyptian population and all. And he is also a member of several professional societies, including AO, Egypt, EOS, ICO, and he has served as a vitreoretinal consultant while keeping the strong academic commitments also. He is also working on the macular buccals, which has seen recently. He has a publication on the titanium macular buccal, what he has done. And today he is there to give us his experience on the titanium macular buccal, how it works in myopic traction maculopathy. What to you, Dr. Mohsen? Are you there, sir? Dr. Mohsen? I think he has not joined at Dr. Mohsen. I think because he has not joined, I think we can present with the next presentation with Dr. Miriam. If she is available, I think next person can moderate that talk.
Hello.
Yeah.
I share my presentation.
Dr. Dhruval?
Yes, yes.
Yeah.
Good evening, everyone.
Yeah.
Good evening, everyone. Good evening, everyone. A very warm welcome to all our attendees. I am Dr. Dhruval and I will be your moderator for this session. It's my honor to introduce our esteemed speaker, Dr. Mariam Abdeloui. She is currently professor and vitreoretinal surgeon in Department of Ophthalmology at University Hospital Hassan, Morocco. She is author of several national and international publications. She stands out as a leader in a retinal surgery and ophthalmic education in Morocco, recognized for both her clinical expertise and her dedication to advancing eye care. She will be enlightening us on a highly relevant intrinsic topic, management of hemorrhagic CDs in complicating cataract surgery. Please join me in extending a warm welcome to Dr. Mariam, and let's look forward to an engaging and educational session ahead.
Thank you, doctor. You hear me? Hello.
Yes, ma'am.
I try to share my screen. You see my screen?
Yes, ma'am.
Hello, dear colleagues. Thank you for the invitation. Today, I'm pleased. It's a pleasure to present my work about how to manage hemorrhagic corneal detachment followed by complicated cataract surgery. It is suprachoroidal hemorrhage. It's a very serious and feared complication of intraocular surgery, including cataract surgery. Fortunately, it's very rare in the area of focal emulsification and microincision. But it remains a challenging complication to manage, and the main problem is there is no standardized surgical approach for suprachoroidal hemorrhage. A brief review about physiopathology of this condition. In the presence of systemic and ocular factor risk that damage blood vessels and elevate intraocular IOP, sudden decrease in IOP perioperatively that can cause fluid diffusion from the vortex vein into suprachoroidal space that creates suprachoroidal effusion. This can cause stretching of posterior ciliary arteries already damaged, and it can produce rupture of lead to rupture of arteries and form the suprachoroidal hemorrhage that creates shallow anterior chamber and red reflex loss. So the bleeding can exceed the equator, and the expulsion of intraocular content through the surgical incision can happen. It defined expulsive hemorrhage. This is a very dangerous complication, and it's a sight-threatening complication. How to diagnose this condition? The suprachoroidal hemorrhage may be diagnosed clinically intraoperatively when you observe the signs, clinical signs that defined below: anterior chamber, shallow anterior chamber, loss when you lost red reflex, and postoperatively we use base scan ultrasonography. It plays a critical role to confirm the diagnosis. If suprachoroidal hemorrhage appear like a hyperechoic solid appearing and irregular choroidal detachment, it shows the location and size of suprachoroidal hemorrhage and assesses the state of the retina and the vitreous. And it allows monitoring the progression of to liquefaction of the clot, and by visualization the decrease of density of the clot, and it allows us to choose the best time to do the surgical drainage. And the ultrasonography identifies the site of surgical drainage based at the highest peak of suprachoroidal hemorrhage. The question in how to manage this complication. When intraoperatively, when you suspect suprachoroidal hemorrhage, immediate pressurize the eye with the immediate closure of surgical incision is required to elevate IOP and to stop bleeding, followed by aggressive medical therapy to control inflammation and intraocular pressure. In some cases, postoperative surgical drainage is required, and it's done either transscleral way or transconjunctival drainage, potentially combined with PPV. And the main and the important question is when to do surgical management. There is no consensus about the timing of surgical drainage, but preferably waiting 10 to 40 days to have a blood liquefaction that facilitates the surgical drainage. When to do the drainage, and the indications of drainage is large choroidal hemorrhage that involve or no the macula, concomitant vitreoretinal involvement, or inability to control elevated intraocular pressure. Here is a real-life case that illustrates how to manage this complication. This is a 60-year-old man referred to our department to manage complicated phacoemulsification of the left eye 3 weeks ago. On examination, the visual acuity was limited to counting finger with corneal edema, lens masses in the anterior chamber and vitreous, increased IOP despite medical therapy. Base scan ultrasonography shows temporal suprachoroidal hemorrhage involving the posterior pole. Here is the surgery. We start with insert cannula, infusion cannula, and we check it. It isn't visible in vitreous cavity and it doesn't drain the hemorrhage. After filling anterior chamber with viscoelastic, we try to aspirate all lens masses in the anterior chamber. We clean it, we clean the anterior chamber, and we decide to insert 23 gauge cannula at 6 millimeter from the limbus tangentially to the sclera in the highest peak of the suprachoroidal hemorrhage. You see here that it allows us to drain liquefied blood. It become through the cannula, and we increase the flow of the blood by filling the anterior chamber and by mobilizing the cannula, and it allows us to drain a maximum of hemorrhage. We insert infusion line, and we check. After this, we check vitreous cavity. The choroidal detachment decreased, and we decide to remove the sclerotomy. We put the third cannula, and we aspirate all lens masses which are free in the vitreous. The vision was blurred, so we decide to remove the epithelium. We are tracking all the lens masses in the vitreous cavity. We aspirate with cutter. We aspirate all the lens masses, and we see here the vitreous is still attached. We inject triamcinolone. We try to induce PVD, but it fails. We inject trypan blue, and we create a hole that allows us to detach all the posterior hyaluid and to induce complete PVD. So we decide to complete the ILM peeling to prevent developing epimolecular membrane in this inflammatory condition. So we complete with the peripheral vitrectomy under indentation. We put three-piece foldable IOL in the sulcus. And we finish with fluid air exchange. And this is the follow-up after 1 month. The visual acuity was 0.1 with a clear anterior segment and reattached retina and complete disappearance of choroidal detachment. Thank you for your attention.
Thank you so much, ma'am, for your elaborative presentation and videos. I still remember the day when I was posted with one of my consultants, and she was doing SFIOL case, and we were trying to insert the PMMA lens through the tunnel. And all of a sudden, because the tunnel was not so good, it started leaking, and due to for a long time, pressure was very low, intraocular pressure, because of the leaking tunnel, and all of a sudden the IOL which you are trying to remove, that automatically came into the anterior chamber, and I first time evidenced that how a suprachoroidal hemorrhage looks. So it was literally a nightmare for me to see that. So ma'am, I have a question that at that moment, does any intervention is needed, or we should just close the case and we should see post-operatively, and after few days after liquefaction, as you told, then we should do the surgery again?
You mean immediately when you have a complication immediately?
Yes, ma'am. Any intervention is needed that moment itself, or we should wait for the liquefaction of the blood and then only we should intervene?
Yes, no. The emergency is to close incision and to raise the IOP to stop bleeding in immediately. Not drainage. The drainage is not recommended immediately because the drainage can reappear after first drainage, and we can have most complication. So immediately you have to close the incision and to increase the IOP to stop bleeding. And most cases, if it is a very small suprachoroidal hemorrhage, we can manage it just medically.
Yes, madam.
Mm.
One more question I have, ma'am, that any role of putting the, like filling the vitreous cavity with PFCL, or is PFCL should be used to raise the IOP?
Immediately when with the complication, or after complication when we do the PPV?
No, immediately if I want to close the case, or temporarily if you want to increase the IOP. So is there any use of PFCL at that moment?
We can't use PFCL without vitrectomy.
Okay, ma'am.
We can't use PFCL, but we have to close and to rise because the problem is when you open the eye, there is an decrease, an acute decrease of IOP. You see, when you open the eye, so you have to close the eye very immediately and very quickly.
Yes, ma'am. I'd like to invite all other attendees and speakers. Any questions?
Yes, I have one. First of all, Miriam, amazing presentation. Well managed. I have a question. So, do you have any like criteria when not to do a surgery in a patient with a recurrent, like a choroidal hemorrhage? For example, after these 2 weeks until you wait, for example, to regards visual acuity, there is a time that you say, okay, it's better to just leave the eye as it is. Do you have any criteria regards visual acuity, age of the patients? State of the high criteria?
Yes, there is a lot of criteria. If the eye after you close the eye immediately, and you have to follow up and to monitor the eye. If the eye there isn't if the size of the choroidal detachment is still one quadrant, okay. If there isn't a lot, the eye, we can manage IOP with just medical treatment. And we can manage inflammation with medical treatments. And there isn't involvement of retina or vitreous. There isn't a vitreous hemorrhage. There isn't a retinal detachment. And we can manage. The problem is with IOP and with inflammation. If we can manage all this and the macula was not involved, if you have these criteria, you can wait and you can see and you can manage the case with medical treatment. But like my case, where there is IOP, resistant IOP, elevated IOP, we can't treat it with medically. And with masses, you see, in my case, there is a corneal edema with masses, with crystal lenses masses in the vitreous, in the anterior chamber, and there is an involvement on the vitreous. So in this case, we have to do the surgery, and you have to do surgical drainage.
Thank you.
Thank you.
Any other questions? If no other questions, we can move to the next presentation. And thank you so much, Dr. Mariam, for such a elaborative session. Thank you, ma'am.
Thank you. Bye.
Thank you. I am Dr. Sharath. I am moderating today the next session. I'd like to introduce Dr. Mohsen Abu Shosha. So he is a distinguished vitreoretinal specialist and a lecturer in the Department of Ophthalmology at Alexandria University, Egypt. So he has many publications, including on the OCT, and contributed to various studies on nerve fiber layers. And recently, he's also working on titanium macular buccal in his research studies publication, which I saw. And he is also a member of several professional societies, including AO, Egyptian Society, ICO, and ESORS. And he is a practicing vitreoretinal consultant and a strong academician also. So I like to call you to give his experience on titanium macular buckle in myopic tractional maculopathy. Over to you, sir.
Yeah, thank you so much for the introduction. You can hear me?
Yes, sir, we can hear you.
Yeah, thank you. And I'm sorry for the inconvenience. Today, my presentation is about the new titanium macular buckle and its use in myopic tractional maculopathy. Pathologic myopia is one of the leading causes of blindness all over the world. And pathologic myopia involves about 3% of the world's population, about 240 millions, and forecasted to be about 10% by 2050. Half of eyes with pathologic myopia have a posterior staphyloma, and about 40% of eyes with posterior staphyloma progress significantly to visual impairment in about 13 years after the age of 40 years. When we go to the pathogenesis of myopic tractional maculopathy, physiologically the retina is a multi-layered, multicellular structure held together by tangential centripetal forces exerted by the molar cells and the external and the internal limiting membrane. In myopic tractional maculopathy, there is a centrifugal forces. The first one is perpendicular, caused by elongation of the sclera and the vitreous traction. These cause schisis and foveal detachment. And the other centrifugal forces are tangential forces causing the lamellar and the full thickness macular hole. For the time being, the current interventions for myopic tractional maculopathy and myopic macular holes with or without ILM healing techniques. And according to the myopic tractional maculopathy staging system by Barbara Parolini et al., most of the cases of myopic tractional maculopathy could be treated successfully and simply by macular buckles. And in cases of full thickness macular hole, vitrectomy and ILM peeling and flap could be added. Macular buckle was first described by Skibbons in 1957, and now we have very big varieties of macular buckle. We have the AGL macular buckle and the T-shaped and underplumb adjustable macular buckle, and recently the titanium macular buckle. The titanium macular buckle is a single size and single shape buckle, what we call one size fits all, with a concave plate for indentation of the macular area. Its application is very simple. It enables hanging of the recti with about 20 millimeters behind the limbus and 5 millimeters apart suturing, and then go to inside the eye and be sure that the buckle under vision is under the macular area, well indenting the macular area. And after that, we do a permanent sutures of the buckle, and we can add or we may not add vitrectomy as indications for associated myopic macular hole. I will start by my first case. She was 75 years old female, presented in May 2022 with dropped vision in her left eye. She was pseudophakic with axial length of 29.3 millimeter and best corrected visual acuity of 0.2. This is her OCT showing the external myopic schisis as we can see, and at that time I advised her just for follow-up after 3 months. However, she missed the follow-up for about 1 year, coming to me with increased schisis and drop vision and metamorphopsia, and this is her OCT after 1 year. At that time, I advised her for vitrectomy because I hadn't macular buckle at that time. But she refused and missed follow-up about 6 months later, coming with more dropped vision, and the schisis cavity increased more. At that time, I had a macular buckle, and I discussed with her to do her just macular buckle. And this is the picture after 1 week of the macular buckle. Visual acuity improved to 2.1. Follow up after 4 weeks, the visual acuity improved more to 0.2. As we can see, the scatic cavity completely disappeared, and we can see the macular buckle with well indenting the macular area. Again, follow up for 3 months, visual acuity is stable, 0.2, and I am still following up this lady now for about 2 years with stable visual acuity of 0.2. My second case is a lady of 55 years old presented complaining of dropped vision in her right eye. She was also pseudophakic with axial lens of 31.1 millimeter, best corrected visual acuity of 0.1. We can see area of sensory retinal detachment with tractional membrane inside the vitreous cavity. And this is 1 week post-operative, the visual acuity after indentation with the titanium macular buckle. The visual acuity improved to 2.1. And this is 1 month. We can notice that the indentation is not perfectly central in this case. However, the titanium macular buckle is doing well and indenting the macular area, and the vision improved to 2.2. And this is the follow-up of 1 year and 8 months now, and she has still a stable visual acuity of 0.2. This is my third case. She was a lady, 71 years old, pseudophakic with axial lens 31.8 millimeter, with best corrected visual acuity of 0.05. She has a myopic schisis with a full thickness myopic macular hole with a base diameter of about 1,500 micron. First, I did her just vitrectomy because I hadn't the macular buckle at that time, and I did her the temporal eye length flap. I secured the flap using perfluorocarbon liquid, air fluid exchange, and 20% SF6. This is the picture post-operative. We can see that the schisis is still present and the macular hole is still open and increased actually in size. So after 2 months, I advised her to do just macular buckle with gas injection. And this is the picture of the eye after the macular buckle. We can see that the schisis disappeared. However, the macular hole is still open. After that, I advised her to do just amniotic membrane grafting, and I'm following this lady for 1.5 years now. The visual acuity, unfortunately, did not improve. However, the macular hole closed and the schisis disappeared. So in the fourth case, I learned the lesson very good. I have a similar case of myopic macular hole with schisis. So I advised the patient for just combined procedure. I put a titanium macular buckle and did vitrectomy with internal limiting membrane temporal flap, as we can see, secured by perfluorocarbon liquid, air fluid exchange, and 20% SF6. And this is the picture exactly 1 week post-operative. We can see a central indentation of the macular buckle with closed macular hole and disappeared schisis. So in cases of myopic macular hole with schisis, I advise to do combined procedure of both vitrectomy and macular buckle. And this is another case of myopic macular hole with schisis, and this is the post-operative. We can see good indentation with the macular buckle and closed macular hole after vitrectomy with internal limiting membrane flap. We are following our cases with fluorescein angiography for fear of pressure effect of the macular buckle on the macular area, and till now, for about 2 years, we did not find any changes in the choroidal or in the retinal circulation. We succeeded to publish our results in 2 papers till now, and finally, we are taking a home message. Titanium macular buckle is a good option for the management of myopic tractional maculopathy, and the titanium macular buckle is a beneficial addition to vitrectomy in dealing with myopic macular hole with maculoschisis. And thank you.
That's a very nice presentation and a great experience of using
Yeah,
titanium
so
macular buckle.
whole tenant, yeah. So I just called them. The process of creating a new account, I've started it. I have to
Dr.
get
Neeraj,
back
can you
in
mute,
Mumbai
please?
today.
Dr.
So,
Neeraj, can you mute, please?
how to solve this? Because it has showing some due payment. It's right.
Dr. Neeraj, can you mute, please?
The payment
Anyone
is
else
due.
can mute?
So how much of it am I supposed to pay? And
I honestly, I don't know. You know, I mean, technically, when you take the lease, you were supposed to have this already in place.
okay.
So I'm just giving you. Right.
Hello? Dr. Mohsen, can you hear me?
Yeah, yes, I can hear you. Yes.
Yeah. Sorry for the disturbance. That was a very nice presentation and a very nice experience with the titanium macular buckle. I have a few questions to you regarding the one is what is the difference between any advantage of the titanium macular buckle over PMMA AGL buckle? And the second thing is what I saw that this has a 2 heads also where we can suture extra. In your experience, did you see any displacement, or because it is a single size buckle? Do you see any displacement or any incomplete what do you say indentation of the macula? What about your experience about it, sir?
Yes, I already presented a case, which is the second case with
Correct.
decentered indentation of the macular area. However, I can say that the eccentric indentation is very forgiving in these cases. In spite the indentation is not central, however, we can see a very good results with disappearance of cases and improvement of the visual acuity. I always advise for central indentation and be sure that the buckle under the macular area. However, in my opinion, it's a very forgiving technique for the cases.
And what about the advantage of titanium buckle over any PMMA buckles or anything, sir?
Yes, as I said before, it's one size that fits all. It's easy for application, and it's a very inert. There is no reaction at all from the buckle. For 2 years now, we are following our patient for 2 years now. It's very good indentation, very stable, and no reaction at all.
Yeah. So one more question has come in the chat regarding they asked, did you find any cases of atrophy following macular buckle? You have showed us a FA, which has shown very nice, no capillary non-perfusion, this thing. But he is asking any cases of atrophy progression or anything after the buckle?
I did 6 cases till now, ranging from 2 years to 3 months now. And we are following our cases with fluorescein angiography and OCT angiography. I didn't notice any atrophic changes either in the choroidal or in the retinal circulation.
That is great, sir. I think we all want to try the titanium buckle whenever we get here. Still in India, I don't think so. It's available right now. Thanks.
I think they are doing well in taking the certificate
Okay.
for its approval.
That's great, sir. That's great. Any panelists have any other questions? So thank you, Dr. Mohsen, for giving such a nice presentation.
Thank
Now
you.
I hand over to the next moderator, Dr. Abhishek, to continue his talk. Dr. Abhishek, over to you.
Yes. Thank you, Dr. Sharad. So I'll be moderating Dr. Arnaldo, who is a renowned vitreoretinal surgeon based in Sao Paulo, Brazil. He is the head of the Retina and Vitreous Department, also serves as the president of the Brazilian Retina and Vitreous Society, a director in the Ocular Health section of the Brazilian Society of Diabetes, and a member of high impact editorial boards for retina focused journals. His clinical and research interests include diabetic macular edema, ARMD, retinal detachment, and the latest with retinal surgical techniques. So we extend you a warm welcome, sir, and he'll be taking a talk on surgical pearls in diabetic retinopathy.
Thank you. Can you hear me?
Yes, sir, you're audible, sir.
Okay. Thank you so much. I'm going to start to share my screen. All right. Okay. Can you see the screen?
Yes, sir. It's not in full screen, but
Oh, here for me is in full screen.
we can continue like this, sir.
Okay. So first of all, I would like to thank the organizers, especially Dr. Seti, for the invitation. And I would like to say hello to all the friends that I know, especially Motion and Sharif. And I don't know if Isolif is still there. And all guys that are presenting to this terrific meeting. I'm enjoying very much, and I'm learning a lot with you guys. Thank you so much. Before I start, I would like to invite everybody to attend next year the 50th Congress of the Brazilian Retina Vitreous Society with a very distinguished international guests, also Brazilian guests. So if you want, just join through this website. These are my disclosures, none are related to this presentation. And we're talking about diabetic retinopathy.
Sorry to interrupt, sir, but your slides are
Yeah.
not moving.
It's not moving?
No, sir.
Let me see what happened here. Let me try to share this again. Now you see, it's moving?
Yes, sir, it's moving now.
Yeah, but this is not for me in the title presentation. But if it's okay with you guys, I keep going like this.
It's okay for us, sir.
Okay, so diabetic retinopathy is one of the most challenging vitreoretinal surgeries. And why is that? Because there is a strong hyaloid adhesion to the retina, mainly to the retinal vessels. There's also very frequently hyalodoschisis. There's a strong adhesion against to a debilitated retina. And many other factors can affect the indication for surgery. So I will start with the pearl number one, saying that surgery starts before even the patient enters in the OR. So you have to plan the surgery and check your strategies. And of course, if you are indicating the surgery or not. For instance, age and type of diabetes. type 1 versus type 2, if it's a young fellow or an older person. What's about the fellow eye status? Sometimes it's very frequent the patient lost the other eye due to the retinopathy and frequently after surgery. If the fellow eye has a good vision or poor vision, and about the previous treatment, if it was done complete photocoagulation, or there was no laser at all, if it was used intravitreal anti-VEGF or not. All these factors can affect your surgery. And not only the retina matters, but also you want to check about the anterior segment. And you're looking if the patient is phakic or not. If it is phakic, there is a cataract, if there's rubeosis, or even worse, neovascular glaucoma. And also check about the pupil size. Sometimes those patients, they don't dilate very well, so you're going to have trouble to check in the periphery. So in the posterior segment of the eye, what kind of detachment we are dealing with? Mainly tractional, or is tractional with rhegmatogenous? And how about the traction? Is there a tabletop traction retinal detachment that we all know is very hard to dissect? And also if the macula is involved or not. And about the vision, how is the vision of the patient, and about the prognosis? And of course, the patient needs to go to the surgery, but before going to the surgery, patient needs to understand the real situation, because sometimes the expectations of the patients is different what reality will come after the surgery. So let's say about these hypothetical cases. Does all they need to go to surgery? For instance, a very fresh vitreous hemorrhage with no traction retinal detachment, or a vitreous hemorrhage with no involving macula tractional retinal detachment. On the other hand, the very long case with a long-standing tractional retinal detachment, usually with a poor visual acuity. There is a predominantly fibrous tissue without macular involvement. The patient has a fairly good vision for the condition. Do we need to go for surgery for such cases? Let me start with this case. This is a 30-year-old white male, came for a second opinion because he had a decreased visual acuity in both eyes 20 days before. He's diabetic for 30 years and no other comorbidities. So visual acuity was 20/125 and 20/62 in the left eye. And there's no rubeosis, clear lens, everything okay except for the hemorrhage, as you can see in the right eye with the subhyaloid hemorrhage. So we have several options just to observe, because it was fairly new hemorrhage. There was no tractional detachment, or we can jump into the vitrectomy or do anti-VEGF and wait to the clearing of the hemorrhage and do PRP, or just treat with the anti-VEGF or only PRP. So many options. What I did to this patient, I started doing intravitreal anti-VEGF and PRP in both eyes and close observation. To make a long story short, this is 1 year of follow-up, no surgery. I did 6 injections and visual acuity was 20/25 and 20/32. 4 years after the initial presentation, vision is still good, few more injections, and things seemed pretty good until this patient called me and said, "Hey doctor, my vision dropped on my right eye." And I said, "Well, come to the office," and the vision was 20/80. And if you can see in the arrow and the red circle, there was a hole. So this was no longer a tractional detachment, but also a detachment with a hole. And as you can see in the OCT, the macula and the fovea was involved. In this case, there's no doubt about everybody goes to surgery. So here is the surgery. I don't know if I can. Let me see if I put in the. Can you see the surgery? No.
Not right now, sir.
Because I think in this mode I cannot, the video cannot run. Sorry about that, but I don't know why it's not advancing in the full screen. So what I did in this surgery, I removed all the tractions, and at the end of the surgery, I left the eye with only air. I didn't put any other kind of tamponade. And 1 year and a half after the surgery, and then we are talking about 6.5 years after, the vision of this eye was 20/20 and with the surgery, and the other eye with no surgery is still 20/25. Sometimes, period number 2, sometimes you don't need to jump into surgery. You must see your patient as a whole and what he wants and all the other conditions. This is another case. This is a 20-year-old white female with diabetic for a long time, systemic hypertension, and he was in a pre-dialysis renal stage. So the clinical situation was not in a good shape. So 3 years before, that was how she presented to our clinic with a lot of new vessels, yet the vision was quite good at that time. So at that time, what we did, we start with anti-VEGF and laser. So patient was lost to follow-up for 2.5 years. When she came back complaining about decrease of visual acuity in both eyes, 60 days, 2 months before. Vision acuity was hand motion, and the fundus examination with the vitreous hemorrhage and tractional retinal detachment. So in these cases, we jumped into surgery, and we performed surgery in both eyes within 10 days apart from one to the other. And the patient did well at the end of the surgery, and we have now 9 months follow-up with a fairly good vision. I would say like the 20/50, 20/60 in both eyes. But this means that the diabetic retinopathy is relentless. And even if you treat properly with laser and anti-VEGF, the disease can continue, especially in a young fellow with type 1 diabetes. This is another case that a patient with a 54-year-old male with decreased visual acuity for 3 months on his left eye. He had a past ocular history of laser photocoagulation, and he has been diabetic for 18 years. The visual acuity on the right eye was quite good, 20/80, and the other one is counting fingers at 3 meters. There was no rubeosis, and there is a very small cataract. So what we did, we performed the surgery to trying to remove all the tractions. In this case, we used the technique of dissecting the membranes and isolating all of them. And again, it's a shame that the video is not running. So 12 months after the surgery, vision went from counting fingers to 20/40. And of course, not only for the surgery, but you complete the laser photocoagulation to the entire retina. And here's the OCT 1 year after the surgery. So, period number 4, during surgery, this was supposed to be related to the video when I showed that there was a hyalodoschisis. So you have to, when you think you remove the hyaloid, you have to go back and check, because very often you find that the hyaloid is still attached. You have to remove the second layer to ensure that you leave no hyaloid attached to the retina. And when you remove the tractions, try to do gentle maneuvers and going tangential to the retina. Don't try to pull in the anterior-posterior movement, because most frequently you end up making a hole in the retina. Remember, the retina is already very debilitated by the retinopathy. So, in the end, I always check the periphery. In most of the cases, I complete my laser, especially in diabetic type 1, up to the ora serrata. This is another case, 30 years old white female, decreased visual acuity for 3 months on the left eye, diabetic for a long time, and she had a history of an incomplete PRP in both eyes. So what I did anti-VEGF 3 days prior to the surgery, and then we went to the surgery. And again, it's a shame you cannot see the video, because in this technique, I was able to remove the traction in the technique called unblock technique. So we remove everything, and in this surgery, again, after removing all the tractions, I went and I saw there was still hyaloid because the hyalodoschisis. And then I stained again the hyaloid and removed the hyaloids and applied the laser to the rest of the retina that needed laser. So unblock technique sometimes is possible to do, not always. In my cases, in the minority of the cases, I can do this. Depends how the traction is. Always, again, check for hyalodoschisis, clean the vitreous base, and complete the laser through the periphery when it's needed. So the take-home message is diabetic type 1 is retinopathy is less forgiveness than type 2. So you must keep in mind that to follow the patient very close and do surgery as soon as possible when you indicate the surgery. When the macula is involved, it's not the only reason to indicate surgery. You may indicate for other reasons, like a long-standing vitreous hemorrhage, for instance, or when you see the traction is away from the macula, but in the follow-up, you see the traction is increasing and menacing the macula area. So then you go ahead and do the surgery. Remember that tractional membranes, they grow stronger and broader with time. So again, consider to do early, earlier pars plana vitrectomy. But sometimes a no-active proliferative diabetic retinopathy, even if there's a tractional detachment, may need a pars plana vitrectomy. Depends on the rest of the eye condition and, of course, the vision of this patient. Anti-VEGF pre and sometimes post-vitrectomy may enhance the final results. According to the first case, sometimes a fresh vitreous hemorrhage with no detachment may be treated initially without pars plana vitrectomy, although you have to follow this patient very closely. A long-term follow-up is mandatory. As you can see in the first case, the patient developed a retinal detachment with a hole 5 years after the treatment. So it's a long-term disease. And be prepared to use different techniques for different parts of the surgery because diabetic patients, they different one to the other. You're never going to find the same kind of patient and the same kind of traction, though you're going to use different techniques to treat that case. So be prepared to go to the surgery for any sort of situations. So again, thank you so much for the invitation. I'm ready for questions, and really sorry about the videos. The videos were really pretty and very beautiful to learn from that. Thank you so much.
Thank you, Dr. Arnaldo, for that talk. We are also very sorry that we could not see your videos. Sir, in the first case that you showed us, what was the reason for repeating anti-VEGFs? We had done PRP for both the eyes, and what was the reason for repeating anti-VEGFs for that patient?
Yeah, well, that patient, first of all, he didn't want surgery. He came to my office and he said, I don't want surgery. But the reason to use anti-VEGF, because this patient was never treated before with anything, with laser or whatever. And he was a diabetic type 1, young fellow. So in my experience and also in our hospital here, we are conducting a study that these patients, that when you try to close the new vessels with anti-VEGF, in meanwhile you apply the laser, you can get better results. And why is that? Because the laser, it takes a while to establish and reduce the activity of the disease. And the anti-VEGF, you can do it right away. I'm not, a supporter to treat only with anti-VEGF, because patient can lose follow-up and then end up with a very worse condition than the previous one. So I still believe that a good, very photocoagulation is the for now the answer for controlling the disease.
Thank you, sir. We also have a question in the chat box. So, do you routinely inject your cases prior to the surgery, and how many days before surgery? And the third part is, do you inject at the termination of your surgery as well?
I try to. I always have the intention to inject, and but there are few conditions that you must be aware of. Number one, the clinical condition of the patient. You're gonna make sure that the patient, regardless if you inject 1, 2, 3, or 5 days before, is clinically stable to do the surgery, because otherwise you can make worse with traction. Second of all is what's the size and the extension of the traction, and if the macula is involved. So link it to the first one. If there is traction, I would say less than 1 disc diameters, I'm not afraid to inject. Okay, so my intention is always to inject before, and usually I inject 1 to 3 days before. And why is that? Because depends how can I book the OR. It's just a matter of doing, and of course I try to do as close as to the day of the surgery, because before I inject, I check if the patient is well, and he can go to the surgery. And I think there was one other part of the question.
Yes, sir. Do you inject at the end of the surgery as well?
Usually in diabetic type 1, yes. And also we are conducting a study here that we inject not only at the end of the surgery, but we keep injecting for up to 6 months after the surgery, just to try to avoid the rebleeding, which is, we all know this is very common in diabetic surgery.
Sir, I would like to ask. Yeah. So, sir, in diabetic vitrectomy, after completing a diabetic vitrectomy, there is always an apprehension of a rebleed on post-op day 1 or 2, So, my question to you is, if there is such an apprehension, what kind of tamponade would you go for? and why?
Yeah, thanks for your question. That is a very important question. Before choosing the tamponade, what I do in surgery to check if could be a very early bleeding, what I do is I decrease the IOP and leave one port open and just observe. Sometimes you can see a tiny bleeding for a tiny new vessel in the retina. If you are able to see this, spot this, you go there and do laser. So then it's one less new vessels that can bleed at the end. The majority of the cases I try to use air or C3F8s. I really want to avoid to use silicone oil because I think there's several complications about that. And but I like to use C3F8 and or air. Depends on the case. But you know, bleeding is sometimes unavoidable, and but most of the time they clear by itself after 2, 3, 4 weeks after surgery.
Thank you, sir.
Elegant presentation, Arnaldo. Here is Mohsen Abu Shusha from Egypt. I just want to ask you for how long you can accommodate the post-operative vitreous hemorrhage before washing the vitreous cavity again.
Okay, if there is no retinal traction, especially in the macula, I can wait up to 4 weeks. If it's not clearing after a month, let's say, then I tend to go again inside and see. And if you go again, you have to go again. Another tip is to check, the source of the bleeding. Sometimes the source of the bleeding is in your sclerotomy site. So you gotta indent and check because probably there's new vessels there and not in the retina. Sometimes you look at the retina and you don't find any, and you say, "Well, where is it coming from?" So check the periphery, check the sclerotomy sites. Sometimes you can see there's tiny vessels there.
And do you believe in cryo as a sclerotomy size that can decrease the incidence of post-operative hemorrhage in diabetic vitrectomy?
Well, I don't have experience with doing cryo in a routine basis. Sometimes I believe that you have to do a complete PRP, very going to all the retina and sometimes going up to the ora serrata. So when you do this, you have to sometimes to wait to the disease to calm down, to go to a state that is active to inactive.
Yeah. Thank you. Elegant presentation. Thank you.
Thank you, Dr. Arnaldo, for this talk. I think we are running out of time. I'll hand over the session to the next moderators. Thank you, Dr. Arnaldo, for your talk. Thank you.
Thank you so much, you all.
Dr. Lockwood has joined from the previous session. Can we take that talk now before we move to the next session?
Yes, definitely, sir. We can take
Okay.
Dr. Lockwood's talk first.
Okay, so it's a pleasure for me to introduce Dr. Akin Sosa Lockwood, who's a vitreoretinal surgeon and a clinical scientist with a very passion for pediatric retina. After completing his ophthalmology training in Dominican Republic, he served as attending faculty in posterior segment surgery before joining Bascom Palmer Eye Institute. So welcome, Dr. Lockwood, and over to you.
Thank you so much for the presentation. Can you hear me well? Yes?
Yes, we can hear you.
Perfect. Can you see my screen?
Yes, it's visible, but it's minimized. It's not full screen,
Okay,
right?
perfect. So thank you so much for the invitation. And I'm not here to talk about pediatric retina at all. I'm talking about a new hot topic that is there, and it's intraoperative fluorescein. I'm going to show a few cases In this case, we decided to do fluoroscopic vitrectomy. And after diluted fluorescein injection, you can see when the dye starts clearing that the posterior border of the hyaloid becomes very visible. And when I was trimming the hyaloid, this iatrogenic bite to the supranasal tear revealed this thick subretinal fluid stained with fluorescein to come out. And I think this is a very useful tool in cases where you can't find the hole. Instead of injecting blue, like we already know that is toxic, this is a much safer technique. So in this case, after this, I stained the macula. There was a posterior membrane there, and then instilled PFO to try to stabilize the retina. And you can see more stained fluid coming out. A peripheral Starford was peeled, and then we moved to the peripheral shave, which I think is it's a very good indication for this because you can see very well the vitreous curve in all dimensions for a very good trimming, and especially useful in trainees. Moving forward, this we perform fluid exchange, and you can see that there's no trace of the dye. And we lasered the tears, and this patient had a very nice outcome with C2FA as a tamponade. This is another case. This case, a more regular case, a macular hole. Actually, this was my first fluoroscopic vitrectomy case. And after the diluted injection of fluorescein, you can see that all of the posterior vitreous was still attached. You can see very well the borders of it and the peripheral vitreous to trim. And you can inject fluorescein intravenously, like we do in the office. This case was a vitreous hemorrhage secondary to a BRBO, and you can see the areas of non-perfusion. And seeing this, you can, instead of guessing where to treat, you can treat just the avascular area, preserving healthy retina. And in cases of diabetic retinopathy, this is another indication. In this patient, for example, after delamination, you can see that there are a few hotspots around. Dr. Borden was just talking about that. And if you treat this hotspot with laser diathermy, you will see that in the post-op period, you'll have less vitreous hemorrhage for sure. And this is how we do it. And this is our protocol at the hospital. So we use the Constellation machine. And you open the light source, you'll find these filter holders that are installed in the Constellation. So basically, we bought the filters online, and you can just glue them into the filter holder. And this is how you get the excited filter, which is 485 nanometers. And this is the setup in surgery. The first step is to parafocalize, just to have like all the retina focus so you don't miss any detail. Then we change the illumination source to the excited light, and in this case, white field and chandelier. Then we raise up the parameters to maximum because the filter blocks some of the light, so you can see a bright image. We activate our barrier filter, which is digital, and then we ask anesthesia to inject the medication. And that's all. Once you get this in the team, like used to this, in 1 to 2 minutes, you can change from regular visualization to intraocular FA and from intraocular FA to regular visualization. So I think it's very good. So in conclusion, I think it's a very good technique. You can see subretinal fluid, you can address retinal vascular disease, and it's very, very, very useful and safe. So like how to obtain the image, this is the same thing we were talking. You can see the physical exciter filter, and this is the parameters just to share with you that we're using. And basically how this works is that you digitally turn down the signal of blue and red, and you enhance the signal of the green to have a grayscale image similar to what we do at the office. And we decided to conduct this study just to, under the hypothesis that intraocular improves surgical outcomes in diabetic retinopathy. We did this retrospective chart review of 108 patients with PDR who underwent PPV. And we divided that cohort in PPV with intraocular and PPV without it. And we got a general rate of post-op vitreous hemorrhage of 25%. But when you divide that in groups, you can really see that the rates of vitreous hemorrhage was less in the intraocular group. And when you divide that by grades, you can see that the patients who received intraocular had milder grades of vitreous hemorrhage, which was statistically significant. Moving forward to this, and I think this is new, intraocular allows the surgeon to see the foveal vascular zone directly after delamination. which can be a predictor of visual acuity. So we get the finding subjectively, obviously, in 16.3% of the patients. And when we compare that to the visual acuity, you can see that the patients with macular ischemia had worse visual acuity over time, obviously. So I think it's important and for the patient to know what to expect after surgery because of the findings. And very importantly, zero complication rate in our cohort. We've done more than 300 of these surgeries with zero side effects. And in conclusion, I think intraocular FA improves understanding of retinal circulation, improves the identification of residual neovascular leakage, gives the surgeon the ability to visualize microvascular ischemia in real time, and reduces complication rates, including vitreous hemorrhage. Thank you so much for your attention, and open to any question.
Thank you, Dr. Lockwood, for that excellent presentation. Very unique use of fluorescent dye for the vitreoretinal surgery. So we have a question in the chat box. Does anyone get nausea during the dye injection in any of your patient?
Oh, not at all. I think it's a very rare side effect. You can have it, but it's very rare. And whenever we talk about this in webinars, everybody has their own way to do it. Some people inject metoclopramide before to prevent nausea. Some others inject steroids. Some others could inject like intravenous anti-allergic medication. But it doesn't matter what you do. I think the rates of nausea and vomiting is too low.
Thank you, Dr. Lockwood.
Personally, we've not had any case with nausea or vomiting during the surgery.
Okay. You mentioned that you found it better than brilliant blue dye during surgery for the first surgery that you showed. So any specific advantage you see compared to brilliant blue dye when you use intraoperatively?
Yeah. So what I was talking about was whenever you have a retinal detachment where you can't find the hole, there's described in the literature that you could inject blue below the retina to identify like this retinal fluid coming out.
Yeah.
But we already know that blue is toxic, and there are some reports about with retinal atrophy afterwards. So we have in vivo studies with fluorescein that says that it doesn't affect the retina and that the dye disappears 2 hours after the surgery. So even if you use and there's some remain fluorescein, the next day you won't see it. So I think that is one of the indications of the fluorescein in these cases. And the other thing is that I think that with this, you don't need triamcinolone anymore to see the hyaloid. You just come inside the eye with the correct dilution, and you will see everything, if the hyaloid is attached or not. So you can play with this, you can play with the filter to get on a very nice image.
Thank you so much, Dr. Lockwood, for those insights. Maybe we can move on to the next session.
Thank you so much.
Dr. Isha, thank you so much. Dr. Isha?
Thank you, Dr. Niroj. Thank you so much. That was an excellent session. Now I welcome you all to the last session of the day. And our first speaker is Dr. Juan Carlos Gutierrez. He is an excellent glaucoma and vitreoretinal surgeon. He is the recipient of the Rhett Buckler Award multiple times, which speaks for itself. So I welcome him to give his talk on luxated and subluxated IOLs. Welcome, Dr. Juan.
Good afternoon. Thank you.
Hi.
Hi, let me share the screen. Here it is. Can you see my screen?
Yes, we can see your screen.
Okay, thank you. Well, good afternoon. Thank you for the invitation. My topic today is going to be management of luxated and subluxated IOLs. Give me a second here. I have no financial interest to disclose. We have different IOL platforms in the whole world. We have rigid PMA lens, the old ones. We have foldable one, 3 pieces, plates, loops, different ones. I'm going to talk just about the ones we have here in Costa Rica. We don't have the Acryos, which is long seen in the literature by Goretex fixation. we don't have it, so I'm not talking about that. There are also aphakia correction design intraocular lenses. We have 4 examples here. That's far beyond the goal of this presentation. I'm mainly gonna talk about my experience when you have an intraocular lens out of place. It can be luxated or subluxated. That's like a chart of how do I think that the approach, but it's simpler than it seems. It goes all the way to 2 surgeries, and with a little shift in between with almost any kind of lens and that you can find luxated or subluxated. Well, first thing of all, we have to elevate the intraocular lens to the anterior chamber. We can do it with forceps, we can do it with silicone tip vacuum, or we can do it with the vitrector-proof vacuum. It's mainly the same thing. My preferred choice is with the silicone tip. You just go all with the vacuum, put it into the iris plane, and then you grab a forceps and you can move it to the anterior chamber. Once we have the lens in the anterior chamber, then we have to find out if you have a 3-piece IOL or 1-piece IOL. If there are 3-piece IOL, then I go to the modified agar wall technique, or now Yamane technique, because I have moved to that one. If it's foldable, 1-piece foldable, and it has 4 optics or is a plate, then I just remove it and go with the same technique with a 3-piece IOL. And if it's rigid, PMMA, I try not to do big incisions in the cornea or in the sclera. So I use Hoffman pockets to fixate it. As it is 1 piece with 2 optics, I use the same technique. Here, I'm gonna show you an example of how I used to do it before. This is the modification of the agar wall technique. It's pretty much the same thing. We do 2 scleral flaps, 180 degrees, one from the other. It's a really good technique. After the scleral flaps, we get into the vitreous cavity in both sides at 2 millimeters. We pull the optics, and there's a little tunnel because the flaps are not that big in order to place the optics so it will be intrascleral. And instead of having the glue, we have to use the Bicryl 8.0. Close both flaps and then close the conjunct. And it's a really efficient technique. The lens is great. But after 2016, Dr. Yamane published shows his technique, and I've moved to that one because it's really fast and is I think it's easier for me than that and faster. There are a little different things. As you can see, I don't place both needles at the same times in the eye because I'm a little bit afraid of that. So I go one by one and then I center. And it gives a good result with a faster time at the OR. If we have one foldable lens with 2 optics or is a rigid PMMA 1-piece lens, then I use a Hoffman pockets technique. I do 2 Hoffman pockets, which begin in the limbus, and the sclera about half of the thickness. Then explant 1 optic and use the Gore-Tex to do 3 loops, and then the tip of the Gore-Tex goes from the back to the front, and that way you tie 1 optic and then repeat the same thing for the second one. As you can see, there are 1, 2, 3 loops, then goes all the way to the back and pull it through the Gore-Tex. Once you have it inside, 2 millimeters to place the sclerotomies between them and from the limbus, and you pull with I like to use the MST forceps. I don't have any interest in that, but it's the one I found easier. I pull the Gore-Tex that way and then do a knot centering the IOL. And that way the single piece goes fine, and the knot, I just push it into the pocket. When we have foldable lens, you can do the same technique. At the beginning, I was a little bit afraid because of the centration, but I've been doing it for more than 7 years, and it works really fine. You just type a little bit harder, and it will be fine. You can use it with multifocal IOLs. You can use it with toric if you know the cornea astigmatism, and it works fine. If you have a subluxated IOL, then you have to think two things. How is the bag? If the bag is fine and the lens is out of the bag, then you can do optic entrapment or just exchange it and put a three-piece in sulcus. And if the lens is subluxated with the bag, then if it's just lateral displacement, you can go with the Hoffman pockets. And if it's total displacement, if it's three-piece, you go back to intrascleral fixation, or one piece, you go back to Hoffman pockets. As you can see, there are only mainly two techniques. Here is a subluxated lens with a very good posterior capsule. So we do the vitrectomy, and then we do a capsulotomy, a circular one, as regular as you can, and trying to leave just a little bit of edge so you can entrap the optic. As you can see, it needs a little bit of push, but it usually holds it good. It's better if the is not so old, the surgery, because it's less stiff. But you can see after pushing there, the optic is really well centered, and it's a very easy technique. When you have the total displacement, like here, you can see we go back to the same Hoffman pockets. This one is with Prolen, and you can just go with that double arm Prolen 590 and like hold the junction between the optic and the aptic, one from the bottom, one from the top, and just tie it and center. I don't like that much the Prolen, but it's really good and it works. As you can see, that's an old video. And when you have a multifocal IOL, those are foldable, the ones we have here, and you see it's subluxated. If you go with the same pockets, you mark the 2 millimeters junction from the limbus and the 2 millimeters between them. But by this time, I try to hold just the optic and aptic with the remnant of the capsule. I didn't want to remove it. So I go from down to up, then go up from down, holding the aptic there. Then I remove pull the Gore-Tex through the pockets and do the nuts, do the same thing with the other side, and just center, cut it, and hide the nuts. As you can see, there's really good results, even though this is a multifocal and foldable lens. So all these things, it comes out to 2 surgeries with a little different shifts, if you can say so. I hope my experience works out for you, and if someone wants to try it or have any question, I'll be glad to help you.
Excellent presentation, Juan. You showed all the possible scenarios in all the possible manners you could have managed the IOL. So I wanted to know if in the Yamane technique, if you have faced that the stress on the haptic optic junction is more compared to the modified Agarwal's technique. Did you experience that?
Between the force in the optic active junction.
Yes.
Yes, I think I don't use the thin wall
Okay.
needle because that one is hard to fit in. So I use just the regular needle. A little bit bigger is the one who comes with tuberculin injection. It goes in easier. I leave it outside, and then I just raise the pressure, and the sclera goes tight on it before I just put it inside. So I don't do that much effort. So
Okay.
but I mean, you do less pressure on that if you go with Agarwal's technique.
Agarwal's technique, correct.
Yeah.
And any risk of exposure in your Gore-Tex sutures when you use them?
I've had two cases. One was in my learning curve because I did the scleral pocket like really thin.
Thin.
Yeah, and after that, I began using a measured diamond knife, so I can go all the way to 300 microns. So I know
Okay.
how deep is my pocket. And then I had another case when I was showing another surgery, how I was teaching him how to do the surgery, and then the nut got
Good.
exposed. But
All
I mean,
right.
on plenty of cases, and only those two cases that I know.
Okay. So we also have our expert panelist, Dr. Sevda Hamatova from Baku. Would you like to ask any questions or add any pearls to this discussion? Sevda, are you there? You muted.
Hi everyone. I'm so glad to see it, everyone. So actually, I prefer all the time. I prefer Agarwal techniques because patient's complaint is less than other techniques, of course. But sometimes just we take the subluxated lens or luxated lens. Sometimes the lens damaged. So that's why sometimes I prefer ice claw. But usually I'm doing the Agarwal techniques.
Okay. Okay. We do also prefer Agarwal's technique majority of the times
Yes,
here.
I'm also fellow from India.
Oh, yes.
Yes,
From
of course. That's why
It's a
I
really good technique.
like, and I'm doing what I learned.
Correct. Same here. Thank you. I think we can move on to our next talk. I would like Dr. Vani to introduce our next speaker.
Thank you so much, Dr. Isha. Very glad to be a part of this discussions today. Very interesting cases. I'd like to welcome Dr. Yasin Malik. He is an ardent researcher with over 20 publications. Would share his insights on subretinal foreign body removal with us today. We welcome you, sir. Over to you for the presentation.
Thank you, everybody. It is my honor to be with you today, and I would like to thank my friend Dr. Seti for the kind invitation. So I'm gonna share my screen first. Okay. So can you see the screen? Yeah?
Yeah, we can.
Okay, so in this presentation, it will be more of a case-based approach to highlight all the surgical toolbox required and necessary to extract a subretinal foreign body. So it is the case of a 45-year-old gentleman who came to my clinic 3 years after a penetrating ocular trauma and presented with aphakia, chronic uveitis, secondary glaucoma, ocular siderosis, secondary to a retained subretinal metallic foreign body, as you can see on the retinography, the wide field retinography. So the foreign body was located into the inferior temporal arcade and was encapsulated with fibrotic surrounding tissue and numerous with several shining and smaller metallic foreign body around it. So here the aim was to remove the subretinal foreign body without damaging the adjacent retina. So the patient was already aphakic And we begin with the 3-ports hybrid persplana vitrectomy. Then we did also visco dissection, to improve the visibility of the posterior segment. And after that, we began our core vitrectomy. As we can see now, during the core vitrectomy, the vitreous was very liquefied. So it was liquefied due to the chronic inflammation, but also to the siderosis bulbi. And we can see also several and numerous glistening metallic fragments all over the retina, and with a major disc pallor and retinal vasculitis. So after completing our core vitrectomy, we went to the subretinal foreign body, and the first step is to do a intraocular foreign body laser demarcation for several reasons. First is to circumference the area of the treatment, just to avoid doing any more damage to the surrounding retina and surrounding choroid. Secondly, those 3 confluent rows of retinopexy will help at the end of the surgery to know where to put more rows of retinopexy. So the first approach was to do a unimanual removal approach. As you can see, the 23 gauge forceps created too much tension over the fibrotic capsule and failed to achieve any safe extraction. As you can see also, a lot of smaller fragments were created. So we switched from the unimanual approach to a bimanual approach using a 23 and 25 gauge forceps, and by pulling in opposite directions. So this is what is called the tug-of-war technique that I generally use during anterior PVR removal in closed funnel. So I tried the same technique for this subretinal foreign body, and this permits the enhancement of the visualization of the foreign body and to create a small opening in the fibrotic tissue and capsule around it. However, as you can see, even in this bimanual approach, the tension over the retina and the adjacent choroid was too dangerous to be used again. So I switched again from this technique to another one. So I use the endodiathermy to cauterize the borders of the capsule and to begin my chorioretinectomy. So after elevating and raising the IOP over 60, I did a bimanual unblock removal with the catheter dissection of the foreign body, the fibrosis, and also the underlying choroid, because the choroid was necrotic and it didn't bleed a lot. And of course, we were using high IOP infusion pressure. As you can see, this technique helped to create a plane of dissection, but when the fibrosis was too thick to be delaminated with the vitreous cutter, I used scissors to cut the adhesions with the necrotic choroid, as you can see here, and also to expose the sclera. As you can see here, under the choroid, it was the bare sclera exposed. After removing all the encapsulated foreign body, we can see here safely, I use the handshake technique to position the axis of the foreign body within the axis of the 23 gauge forceps to use another technique which is called the iris shelf technique. So now we will see that with the second hand, the intraocular foreign body is moved from the posterior segment to the anterior segment through the pupil, because the patient was left aphakic for this purpose. And now with the iris shelf technique, the intraocular foreign body is removed safely and then extracted from a corneal keratotomy. But the most difficult part was the common part, because after removing the intraocular foreign body, we had to do a bimanual heat chorioretinectomy. So with a flute needle in the left hand and a cauterization on the right hand, we removed the small bleeding over the sclera and did a bimanual cauterization and aspiration of the subchoroidal blood without creating any extensive hemorrhage. I went through a fluid air exchange without having the fear of any air embolism because the vortex vein were very far from the part of the chorioretinectomy, completed the laser, did a silicone oil tamponade, and after 2 years of silicone oil removal, the retina was left or kept attached without any major PVR. Why? Thanks to the extensive chorioretinectomy. So I think that extensive chorioretinectomy may be the solution to prevent major PVR after those difficult surgeries. So thank you for your attention.
Thank you so much, Dr. Yasin. It was a very interesting case, and you exhibited all the techniques to remove such encapsulated foreign bodies very well. One question which I'd like to ask was that this was an encapsulated chronic foreign body, but in case of a recent injury with recent foreign, do you prefer a complete PVD induction and a complete vitrectomy in these cases, or just a localized PVD induction in the area of foreign body for removal?
I think that complete PVD induction is mandatory in those cases because those cases are very PVR associated cases, and we can have very complicated PVR in the weeks or the days after doing the vitrectomy. So when we keep the posterior hyaloid, it is the basement of the proliferation of postoperative PVR membrane. So doing an extensive vitrectomy with extensive yellow-weight removal is mandatory in those cases, in my hands, of course.
Sure. Thank you very much. And one more question. Have you ever experienced any other, like a glass foreign body or something, which you may have, like we had an impacted foreign body, half glass, which was into the choroid and half in the retina, but a ragged kind of a glass piece. So would you like to leave it there or remove it anyhow?
I did experience it, and I think that glass foreign bodies are the most difficult ones to remove.
Yes.
Generally, the fragment is very big and cannot be removed safely with the endoocular instruments. So generally, we have to do big sclerotomies or go through big keratotomies, even 5-6 millimeters keratotomies, and try bigger forceps through the pupil or the aphakic status and remove it en bloc. But it keeps bleeding. It is very difficult to manage, and I think that viscoelastics in those cases are better than using PFCL. Why? Because viscoelastics is heavier than PFCL and can prevent the underlying retina of being injured while removing or while letting the intraocular foreign body over the retina, while PFCL cannot help raise the foreign body. So this is the main, I think, issue with those kind of foreign bodies.
Thank you. Thank you so much, Dr. Yasin Malik. If there are no more questions, I think we can move on to the next presentation. And I'd like to hand over to Dr. Asif Virani for introducing our next speaker.
Thank you.
Dr. Asif, I think you are muted.
Dr. Asif, yeah. Dr. Asif, you're not audible to us. Dr. Asif, we are not able to hear.
phone him up, Isha.
Ah,
You can phone him up and ask
think
him.
he's yes, sir.
Or you could introduce the speaker.
Yes, sir. That's what. So our next speaker is Dr. Ahmed Al Kashab. He is the head of the Vitreoretina department at the Eye Consultant Center in Dubai. And he will be talking about the uni versus bimanual technique for vitrectomy in advanced diabetic TRDs. I welcome Dr. Ahmed and let's begin with his talk.
Thanks a lot for having me. It is a pleasure and honor to be part of this distinguished group of speakers. And I would like to thank my friend, Dr. Siti, for inviting me to be participating in this. I don't know if my presentation is appearing.
Yes, it's visible, just not in the full screen mode.
Okay. Yeah. Okay. So we are all facing the problem of diabetic patients, and Dr. Brandon had just elaborated the difficulties that we are facing in such cases. Just to name, we started this journey in 1970 by Mackham and co-workers who started the first post-plan vitrectomy for the complications of diabetic retinopathy. And the indications we all know: non-clearing vitreous hemorrhage, traction retinal detachment involving the macula, combined traction rhegmatogenous retinal detachment, progressive active fibrovascular proliferation, macular edema associated with posterior hyaloid traction, dense premacular hemorrhage, dense vitreous hemorrhage, and recalcitrant non-tractional DME. Our objectives remain the same: remove all axial opacities, relieve anteroposterior traction, relieve tangential traction, segment or peel epiretinal membranes, and effective homeostasis. Treat all retinal breaks and deliver the photocoagulation, full or limited, and local treatment to flat NVE. So the question is, should we use unimanual or bimanual? I think both of them should be present during our armamentarium, and we should use them accordingly. So just to move on very quickly, we have some few cases just to present my point of view. This is a 24-year-old female patient, type 1 diabetic, uncontrolled. She came with a drop of vision to counting fingers 1 meter. And let us just see the video. So it's an extensive traction retinal detachment. So I always prefer to start by removing the anteroposterior traction and to try to remove as much as I can all the anteroposterior vitreous without tackling the central part of the membranes. So this would decrease the chance of extending the traction to the periphery and causing or creating any peripheral tears and complicating the condition. So with a minor nudge to the membrane, so minor elevation of this epiretinal membrane and traction. You can see here even minor traction exerting on the optic disc, and with always making sure that you are not exerting excessive traction, you will have a plane, and we can go just with the cutter and remove all this epiretinal membrane. Sometimes what it needs is just a little bit of traction without exerting too much of it. And after that, just using the cutter. In such cases, I'm using always 25 gauge cutters, and you can go underneath this membrane and tackle this all these membranes. And with that, you can just peel all the epiretinal membrane and then diathermize all the residual nodge and just finish with endodiathermy, and just air or gas would be just more than enough. Another case, 61 years old female, male, sorry. He came with an old trauma, a mild one, but he's a diabetic. So he came with the counting fingers, and initially this was the OCT image. And sometimes we will be astonished how the OCT can get a better image than the actual vitrectomy. And you can see here all this extensive fibrosis. So just make again this relief of the anteroposterior traction, and this is crucial not to exert any further traction on the periphery of the retina. You can go as central as you can or as peripheral. There's no problem, but relieve this initial traction. And then you can see here this extensive fibrosis peripheral. I think this is, you can see here, this is tooth posterior hyaloid that you only can remove with a bent 25 gauge needle just to penetrate it, and then to remove this epiretinal membrane and dealing with the traction on the fovea again. So multi-layers of traction, starting from the vitreous, epiretinal membrane, and then the ILM, which in such cases need to be peeled and removed. And in such cases, just a gas or air would be more than enough to control the condition. And this is the immediate post-op image. The retina is totally flat, and definitely the vision improved. This is another patient, again, type 1, uncontrolled. She came initially with extensive rubeosis and neovascular fibrosis that continued. And we can see here that there is a foveal traction and foveal herniation. In such case, I think the earlier intervention would save the day. So we should not wait until further traction to be exerted. Anti-VEGF is crucial with such fulminant rubeosis and neovascular fibrosis. So removing all this membrane tooth posterior hyaloid with bent needle, removing all the traction, uni-manual would be more than enough in such cases. And just removing this with the cutter. And I think the initial step is to do an ILM peel without exerting too much traction on the fovea. And this is the immediate post-op, and this is a long-term follow-up. So in such cases, a crucial step is to do a full PRP, and the vision improved to 20/30 despite the initial foveal herniation that we have seen. This is a more difficult case that came to me. He's an insulin-dependent, very young boy, came with his parents. He came from abroad with query light perception in both eyes, sluggish pupillary reflex, and we gave it as a chance operation. So we went in after anti-VEGF injection, and you can see this, there was extensive hemorrhage cleared initially, and then this is the posterior hyaloid, and again same technique, removal and removal of the anteroposterior traction. just because very important to me not to exert an excessive traction on the periphery. So you can see this extensive fibrosis and the traction on the fovea and the optic disc. And with that, I think bimanual technique was the way to go because we cannot see the points of traction. So minor elevation and just nudging and removing of this epiretinal fibrosis and traction. There is a difference between the scissor of the 23 gauge and to 25 gauge. With 23 gauge, you may go and bite a longer bite. With the 25 gauge or the 27 gauge, you can see just a nipple of, so you cannot get the whole membrane in one go. So always make sure that you are going into the anterior plane, not posterior, not to cause any iatrogenic break or any inappropriate cut in the retina. With that removal of this fibrous tissue, and we can see this amalgam of fluid and amalgam of retina that even with gas, it did not disappear. You stop to clear all the hemorrhage that can develop, and then under proper visualization, removing of the residual membranes. And the cutter can do that just enough, just good enough. Despite I usually prefer gas, but in such case, I do not know the function, and this patient was traveling, so silicone oil was the better choice in my hand for this such patient. And this is the post-op image, cystic spaces, still some elevation, but the vision improved with the silicone oil to 2400. So you can see the stark difference between light perception and 2400. The other eye he was encouraged to do, and this is exact same scenario. Extensive hemorrhage, extensive fibrosis. So you can tackle it layer by layer. You do not know exactly where you will face the retina, but I was encouraged. The patient was much happier to go for the second eye, and again, same technique and removal of this epiretinal membrane with the bimanual technique. And you can see all these folds of the retina. So this membrane has been there for very long time, and we do not expect that the retina would flatten immediately post-op. So giving time is very important for such cases. Again, not to pull too much. Sometimes doing just a blind dissection, and whenever we face any point of potent traction, that's the time that we will cut. And changing the second hand, but without exerting too much traction. This is very important. And not to be carried away during the bimanual technique dissection. Despite the anti-VEGF injection, we definitely expect bleeding, but definitely it is much, much better to deal with that in the context of an anti-VEGF injection prior to surgery. And usually I prefer 3 days, maximum 5 days before. 1 day in my hand, I feel that the bleeding would be still too much. And same, I will not wait. Dr. Brandon mentioned that because of the condition of the patient, we need to make sure that the surgery would be done within the allocated time frame. I usually do all my surgeries under local anesthesia, so no general anesthesia is required, and this improves my choice for such cases. Again, I use silicone oil because the patient is traveling, and I prefer to give him the best vision immediately post-op. And this is the image for the other eye. It is slightly better, and the vision improved to 20/200. So I would, this is another case, recurrent traction retinal detachment. So again, in such case, you should not be going with unimanual, because this is fine, fragile membranes that needs to be removed without any exerting any excessive traction. And in such case, actually, I've discovered this is a referred case that there was an ILM peel done before, and there was a large macular hole. So a free flap ILM was chosen, and to cover this hole. And with that, I think we can, move on. Yeah. And just multiple flaps was chosen because no large flap was we were able to get, and we covered this this hole. And this is the image after the closure of the macular hole. I think with that we can skip this. And my take-home message in both unimanual and bimanual: don't exert excessive traction. Try always to relieve anteroposterior traction first. Maintain homeostasis either by light diathermy or laser. Aim for no iatrogenic tears, as all of us hope, but if it happens, relieve all traction around this hole so that you can improve the success rate of the surgery. And with that, I thank you all for listening, and I'm open for any questions. Thanks a lot.
Thank you, Dr. Ahmed. That was an excellent presentation and beautiful surgeries. I had a question. Do you change the position of your chandelier based on the position of your membrane, or you always prefer the inferior location?
No, it varies. Sometimes I use the superior approach. Sometimes I use the inferior approach according, but I'm using the dual chandelier. So this I can play a little bit with the positioning of the chandelier itself. So sometimes I move it up or down according to the how I will tackle the membrane. So this would give me a little bit of freedom to direct the light in a better way.
Okay. And which is your most preferred gauge for doing these complex bimanual procedures?
I usually use 25 gauge now, seldom that I'm using 23 gauge whenever I feel that the membrane is too thick for the scissor to be cut, but it's very, very minimal cases. I'm not using 27 gauge except still in, for example, macular holes or my fine surgeries.
And in the last case where there was a hole, you had done ILM peeling, but otherwise, if you're operating a diabetic patient and you see chronic edema, do you still peel the ILM or you spare it?
So I was always with ILM peel. Because I feel that I would remove everything on top of this, and I will make sure that there is no vitreous cases, no residual epiretinal membrane. But nowadays, because of the studies that have shown that with that, sometimes the vision would not be as, it would be better even without the ILM peel. But still, I'm using ILM peeling whenever I see any exerted traction on the fovea. But once you do the peel, and this is a point that I need to emphasize, you need to do a good peel and remove the ILM all around the fovea, not to leave any bit of ILM because it will exert attraction. And that's time you will find that there is recurrence of macular edema. So if you remove it, definitely not to exert any unnecessary attraction on the fovea.
Okay. Dr. Sivda, would you like to comment on this?
So Yes, I want to comment about first bimal and uni. In my opinion, actually, manual vitrectomy should be reserved for elected cases. So I prefer to switch only when absolutely indicated. So, okay, I by manual have advantage, has advantage, better traction control, okay, enhanced precision, improved access to difficult planes, and true to-handed surgery, stable illumination. But we have also some risk, phototoxic effect of risk of our chandelier, and also endophthalmitis risk more than simple unilateral cases. So that's why, it's extremely helpful when membranes are too adherent or when single hand dissection becomes unsafe. But in routine case, it may increase the risk of retinal injury, of course, due to extra instrument in the eye. And if we do segmentation, delimitation, very gently, anyway, even in the difficult cases, we can do uni surgery also. I want to say about ILM peeling. I like ILM peeling, but ischemic retina, I'm not doing, because even ischemic retina already, and whatever we will do there very gently anyway with the major fovea. That's why an ischemic already is retina is ischemic. Again, we are doing the island peeling. In my opinion, I'm not doing, and it's not good for fovea. Thank you so much,
Right.
Mr. Ahmed. It's very nice surgery. You have done very great surgery. Congratulations.
Thanks a lot. I really appreciate your words, and I definitely second to your talk. Actually, that's what I would prefer. I would prefer always to do uni-manual. Whenever things are very tough, that's the time to use bimanual, but be always ready to have it. So you have a chandelier ready. You do not need to put it in each and every case from the start. Although it may help for diathermy, but usually even in the first or 2 or 3 cases, I've shown that it is uni-manual is just more than enough. And I don't think ILM was required in most of those cases, except if there is traction or too much traction on the fovea. That's the time I would use ILM nowadays.
Actually, in my not PDR cases, but all of my retinal rhegmatogen retinal detachment cases, all the cases I am doing ILM peeling, because reattachment. Even I have studies about it, about ILM peeling in RRD cases, and it works. It works better than without ILM peeling. Reattach retina risk actually zero, I think.
That's great.
One
But
of the problems with doing an ILM peeling in retinal detachment cases specifically is that the retina becomes thinner in the fovea. And in diabetics, ILM peeling technically it seems very good, but it's a more difficult procedure. Sometimes it's a very sticky ILM, and sometimes the retina is boggy. Then you do risk creating a break unnecessarily. If at all, I mean, it's better to let it settle down and think of it later on, if it's not working out. But one thing I'd like to ask you, Dr. Ahmed, the second case that you did you were you doing diathermy towards the end, somewhere near the disc?
No, not really. Not at the
Right.
disc. Maybe
Because
if it is
it looked
maybe if it is a fibrovascular proliferation and I did not peel it or I did not avulse it from the disc and I found that there is any bleed, sometimes I may do very minor diathermy on this fibrovascular elevation to prevent it from
even if it's
rebleeding.
it was an elevation, but even if it's on the disc, you would go ahead and do it?
If it is
generally,
directly
I
on
would
the disc,
normally avoid
definitely
it.
not. But if it's slightly elevated, yes. And this that usually does not, because you are doing very minor diathermy. It will not propagate to the disc. It is not affecting the disc, because I've seen reverse. Sometimes if you do avulsion of this, not in all cases, but if you do avulsion of this, and this was a stump where the blood vessels are there, it may affect and may cause ischemia later on. So it is always whether to do that or not. If it is not bleeding, I will leave it. I will not touch it, and I will not pull it. But if there was a bleed, I would lightly diathermize to prevent it from rebleeding after surgery.
I agree with you. Normally, I would not touch it, and normally it doesn't bleed. But if you try to avulse it, and if you're not able to sort of take it out gently from the root, then it bleeds. So it's not worth doing that unless you can take it
And
out very
definitely
gently.
no diathermy on the disc itself, but I
Yes,
mean
sort
on the fibrous.
Yes. Okay.
Thank you, sir, for your comments, and thank you, Dr. Ahmed, for your presentation.
Thanks a
If
lot.
no more questions, we can move on to our next talk. I would request Dr. Anand Brar to please introduce our next speaker.
Thank you, Dr. Isha. It is my great privilege to introduce Dr. Dinesh Talwar, an accomplished VR surgeon with over 3 decades of experience. He's an alumnus of the famed Dr. Rajendra Prasad Center for Ophthalmic Sciences at the All India Institute of Medical Sciences, New Delhi. And since the year 2003, after having an accomplished academic career at AIMS, he leads the vitreoretina services at Indraprasth Apollo Hospital as well as Center for Sight, New Delhi. He has 90 plus papers to his name, 350 plus lectures, numerous awards and orations. He is a meditator, a philosopher, and a lifelong learner. So we have many things to learn from you, but today's talk will be on retinal detachment in high myopia with and without macular holes. Over to you, sir.
Flattering introduction. Can you see the presentation?
Yeah, we can see a part of the slide. If you can go into the
I'm
full
also
screen.
having a Let me reshare it.
Yeah, we can see half of the screen yet.
And do this again.
Yeah, sir, may I help you?
Yeah, go ahead.
Sir, click on share button at the bottom side, a green color button. Then a window will pop up. Sir, under the entire screen is showing, sir. Double click on that, sir.
Okay, so let me stop this. Go to this.
Click on share screen button. Then a window will pop up. Then double click on entire screen के नीचे screen है उस पर double click कर
Interior.
Entire screen. First option screen के अंदर है sir.
Entire screen.
के नीचे स्क्रीन है उस पर डबल क्लिक कर दीजिए सर.
ये
आपने क्लिक हाँ किया सर अभी हो रहा है सर या सर वी कैन सी योर स्क्रीन सर नाउ ओपन योर स्लाइड सर या यस सर या ओपन योर स्लाइड सर yes now go to in slideshow mode sir
Okay, but again I have this coming.
ये जो कप है ना हाँ click on slideshow then click on from beginning sir yes इस पर भी click कर सकते yes sir we
Thank you very much.
my pleasure
Yeah. Can we go ahead?
Yes, please go ahead.
Okay, so today we are going to be discussing retinal detachment in high myopia with or without macular holes. And before we go further, there's certain points about high myopia, which, certain anatomic facts which are of relevance. The most important of which is that you can have high myopia without a staphyloma or with a staphyloma. Now, when you have a staphyloma, you must understand what is happening. When this staphyloma occurs, this actually stretches the area where the retina has to follow. And when there's a taut hyaloid, and specifically because of the ILM, which is taut, you get a relative shortening of the retina. See, basically, the ILM is the most elastic structure in the retina. Elastic actually means tendency to go back to its normal position when the deforming stress is removed. Unlike a plastic retina, which will just fall back into whichever space you put it. So if you have an ILM, it will not let the retina settle down. So if you have a posterior staphyloma, the only way to settle the retina in that situation is to remove the ILM, because that's what's going to remove the elasticity of the retina and create a plastic retina which will settle into the area of the staphyloma. Now this is the critical part of that. Now, once you've done the ILM removal, it will fall back, the retina falls back to the walls of the posterior staphyloma. If there's a hole, it'll oppose, and also at the same time prevents recurrent ERM formation. So when you're going to decide about surgery for a high myopia with RD, first thing is you need to see, is there a staphyloma or not? If it's no staphyloma, there'll be a modification. We won't need to do the ILM peeling part of it. If there is a very severe RP atrophy, again, I'll show you how things will change. The other important thing is all these patients of high myopia have actually vitreosis with either a complete or a partial layer of cortical vitreous very closely adherent to the retina. There's also going to be difficulty in ILM flap visualization, which I'll tell you how to handle. Stabilization of the ILM flap over the macular hole is needed in these cases, and complete drainage of SRF without dislodgement of the flap is needed if it's an RD with a macular hole. Now, this is just to show you a patient where you see carefully, we put in tricot. Now, how to see whether there are any remnants? So you remove all the tricot, and then you'll see some little parts of tricot still there. And when you use the diamond dust scratcher, you can see here these are cortical remnants, which even if the retina settles in initially, will become a course of recurrence later on. So this is one important thing. The other thing you can have sometimes, that was little small remnants of cortical vitreous. Here, if you look carefully, once you remove this and you see that there are these little dots of tricot left there, and you see this is a complete layer, and this layer needs to be separated. And I found the diamond dusted scratcher is the best. Forceps doesn't work; it just tears off the of this sheet, so you're not able to get all of it out in one go. With this, on the other hand, you're able to pick it all the way to the periphery. Try not to lose it, and then in the periphery also you'll be able to pick it off, so that as far as into the periphery that you can go, you should clean this up. Now, This is to show you what happens when you're doing, this was a patient with an RD with a macular hole. And now here we are doing an ILM peeling. So we are staining with BBG. And I with the diamond dusted, you can see I'm making small nicks in the ILM. This is with the 25 gauge MVR. And I find that as a very useful instrument for just nicking the ILM and then peeling it off. And as you saw over here, I thought, let me stabilize the retina with PFCL. And so after making those nicks in the ILM, I put PFCL. And after I'd done that, I find that I can't see anything. I couldn't see any part of the ILM because of the concomitant severe RPE atrophy. And so I removed part of the PFCL, now created a big, this is visible, now it's opaque, created a big flap. Now using that big flap, I put the PFCL back again so that now I have a large area of contrast with the normal, with the retina which has the ILM. And then I pick this up, removed it from the lower temporal edge, so all the way into the periphery. You can see that it's going all the way up to the periphery. And then I made sure I don't lose this larger edge over here, a flap over here. Pick it in one go, make sure it goes all the way around in one go. I don't want to, if I lose the edge, I may have a difficulty seeing the ILM again in this area. So I'm keeping this edge with me, taking it all around, and then removing the ILM. And you can see over here, the postoperatively, the retina was well settled. Let's go to the next case. This was another patient with high myopia with what looked like a dislocated IOL. And so we thought we'll remove the IOL and then and he also had a macular hole with an RD. So we made a scleral flap. And incidentally, what looked like an IOL actually turned out to be a capsular tension ring. It wasn't. And with the RD over here, so first we put in PFCL to stabilize the retina. Because this was very bullous, I had to make a small hole and settle the retina. Put PFCL, brought this. So took this out, just shortening the view. And after removing this, close the corneal incision and went back, removed the PFCL, stained first with tricot to remove the layer of the vitreous, because that in these cases can become an issue, and then stained with PBG and created these multiple flaps. This was a very large hole, so I didn't want to just remove the flap. I created multiple flaps over here, brought them all over, all around the hole, put them all into the hole, not pressing into the hole, but just putting it over the hole. And the PFCL here helped me to make sure that it doesn't move from there. And it was all placed, all these multiple flaps were placed. And then I increased the PFCL to stabilize the retina further. In fact, if you put more PFCL, it's easier to stabilize the retina. A little bit of PFCL, sometimes it doesn't stabilize. Brought it in. And then after that, laser in the periphery. I usually do a 360-degree laser of the periphery in cases with our retinal detachment. And then we put in silicone oil and close the eye. Into the periphery, and as I take it into the periphery, separating it out, now you see there's for 1 second in the middle, you'll notice that I went to the edge here without visualization, and I hit the edge of the staphyloma. And this you have to be very careful, because if there's a deep staphyloma, it has a sharp edge. If you don't want a visualization, you can go and hit it and create a break at the worst position for you, which is the edge of a staphyloma. So this is just to show you the that can happen in these cases. So ladies and gentlemen, if you so you can see ILM peeling is critical for success in myopic macular hole with RD, or even myopic RDs with staphyloma, because it allows the retina to fall back. It decreases the elasticity of the retina, and it then settles back along the staphyloma. And I have had very good results by making sure that all cases in which there is a staphyloma, you do a large removal of the eyelid. On the other hand, if there is no posterior staphyloma, then only those cortical remnants, either small remnants or the whole sheet, needs to be removed, and the retina will settle down. So staphyloma, you remove the sheet as well as or cortical sheets as well as the ILM. No staphyloma, you can just remove the cortical sheets and the retina will settle. But it's very important to recognize the presence of that vitreocetic layer. RD with or without macular, high myopic RDs with or without macular holes are challenging. You have to titrate how to do it. You have to change your technique a little bit. Like I had to remove the PFCL, create a flap, and then do it. But surgery is very rewarding, very much.
And thank you so much, Dr. Dinesh Talwar, for that very illuminating talk and very interesting cases, especially the one where what looked like an IOL was a capsular tension ring. I can go to the panelists for their questions, and I have one question of my own. In cases where you have a detached retina with a macular hole, and we are unable to actually assess the size of the macular hole, so how do you decide between a conventional ILM peel versus a flap?
So basically, I think unless it's a very small hole, the OCT is not difficult to find the size of the hole. And if the hole is, say, more than 600, 800 microns, better to put the flap in. If it's smaller, if it's a very small hole, less than 400, you could get away with just doing a peel of the eyelid.
Okay.
Like one of the cases I showed you, we got away with just doing the ILM peel.
Yeah.
But it was a broad peel. The important thing is that when there's a staphyloma, you must peel till the edge of the staphyloma. Then you need to peel the ILM to the edge of the staphyloma.
Any questions from the panelists? Any comments? So if we have time, I have one more question to ask you. Have you had any difficulties with the access to the edge of the staphyloma or going posteriorly?
Very good question, and a very important question. You know, I have never had that problem. And I used to wonder, why is it that the whole world is talking of this problem and I don't have this problem? The reason is I use a Lander's lens. Okay. The reason why you have a problem will be if you use the biome or any variation of that, because then the shaft of the of your forceps will hit the will hit the recite or the biome, and you're not going to be able to go all the way in. So then you need to have you have all sorts of techniques like going more peripherally instead of 4 millimeter, try to go to 6 millimeter, but you need all these things only if you don't if you if you are not using the Lander's lens. The second thing, once in a while it can happen if it's more than 32 millimeters or so, and it's not common to get a more than 32 millimeter eye. Another thing you can try is just remove the cannula. The cannula also consumes more than 2 millimeters. So just removing that trocar, the cannula, allows the forceps to go deeper. That can happen very rarely, but it can happen. So when that happens, and if you find that it's a very, very big eye, then the first step is you can use just remove the cannula. The second step is there are some forceps available which are up to 35 millimeters also. 34 to 35 millimeters. And the last thing is, which I don't like to do routinely because it always carries the risk that you may go and come too close to.
I think there's some
Dr.
issue
Talwar,
with,
I think, yeah, we lost the audio there.
yeah, audio and video both.
Horizontal. So a little more horizontal, that allows you more deeper penetration, a little more peripheral. And of course, before you do these esoteric things, all you need to do is use a Lander's lens. And if that doesn't work for you, remove the cannula.
Yeah. So
It's a
there can be,
sequence.
yeah. So there are very simple solutions to this kind of non-vexing
Yes.
problem.
Yeah, actually, the problem is most of the youngsters have got trained with the recite. They're not
That's what I
used
was
to.
about to say, sir, that we have not
But
been
this is
trained
what,
on landers to use it.
so that's what I'm saying. I couldn't even figure out why you're having a problem. Why are the youngsters
Yes.
having a problem? How come we've never faced it? Because it's very rare to have a 34, 35 millimeter eye. You know,
Yeah.
till
So
that time it'll come.
thank you.
30, 32 millimeters to aa jayega.
Yes.
So it's a very
Interesting
good question.
discussion
I
we
mean,
had.
this is a question that needs to be
Yes.
answered.
Thank you so much for that answer.
Yes, sir.
And we can now move on to the next talk, and I request Dr. Adnan Sheikh to welcome the next speaker.
Thank you very
So
much.
I think, thank you, Dinesh, sir. Thank you so much. The next speaker, due to some reasons, he is not here, but I'll be sharing his presentation. Meanwhile, Dr. Adnan can introduce Dr. Javier.
Hello everyone. Am I audible? Hello.
Yes, you're audible.
Okay. So our next speaker, Dr. Javier Lugar is from Brazil. He is the leading authority in ocular ultrasound, and he is a honorary consultant in Fortaleza, Brazil. He works uh, uh, as a head of imaging at CLDO, Brazil. He trained from prestigious Doheny Eye Institute. He has authored multiple books. One of the notable books is Echographia Ocularia, and he is also a chef. And today his topic is ultrasound in intraocular fluids. So the presentation is in front of you. The video recorded presentation of Dr. Javier Lugar.
So, Dr. Adnan, is this presentation visible?
Yeah, but the video is still uploading.
Yes, I'll just. Maybe I'll just reshare it. Is it now audible?
voice is not audible.
Okay.
Only we can see.
Ma'am, you didn't share sound. Firstly, at the above side of the zoom, stop share के ऊपर एक more करके ऑप्शन होगा, उस पर share sound क्लिक कीजिए मैम. Share computer sound.
Okay.
Then play करेंगे तो आपका audio आएगा.
Use the B
Yes, ma'am,
scan
perfectly
Now?
for
Perfectly
intraocular tumors.
Start
And
from
it's
previous
important to use the B scan appropriately. And I'm going to talk about intraocular tumors. I do use the B scan for the intraocular tumors. And it's important to use the B scan appropriately if you don't have the standardized A scan. The most important thing to evaluation of tumors is to lower the gain 10, 15 decibels to do the evaluation of the tumors. And the second is to know appropriately how to use the probe position to centralize the image. Because this, at the COMP study, it was basically very important to centralize the image to evaluate the vascularity, internal reflectivity, etc. Okay, so in the transverse, you can measure the thickness and you can measure the lateral base, and then you turn your probe 90 degrees and you do a longitudinal cut to measure the anterior, posterior parts of the tumor. And with these measurements, you can do the calculations to do the radiation for brachytherapy. So when we evaluate choroidal osteomas, a tumor, usually in young women, in one eye, usually unilateral, and we can see the images in the retinography and angiography, but you can close the diagnosis when you do an echography. Why? Because it has the bone deposits at the choroid, and it does a high reflectivity, and you have the shadow of this internal high reflectivity of the choroid. When you have one of the complications of the choroidal osteoma, like this young woman that came to the clinic because she lost her vision, it's the neovascular membrane, one of the complications of the choroidal osteoma. We did all the exams, and we could close the diagnosis with the echography because of the high reflectivity of the choroid, the posterior pole with the shadow present at the echography. The choroidal hemangiomas, usually located in the posterior pole, patients into between 15 and 30 years. No, and though it's a vascular tumor, we don't have internal vascularity in the echography. We have very high reflectivity, very homogeneous, usually have this dome-shaped, but we don't have internal vascularity. Metastatic tumors is another tumor, which here the most important thing is the clinical history of the patient. Came to the clinic, it was sent us from another ophthalmologist because a serous detachment. When we did the echography, we did the transverse, the nasal transverse of 3 hours. We saw this lesion, very irregular lesion, with areas of high reflectivity, low reflectivity, medium reflectivity, and basically no internal vascularity. So we always do the transverse, and then we do the longitudinal cut. But basically, this patient was being treated for breast tumor. And look at this tumor, okay? You can see here, very irregular. We can see areas of high reflectivity, low reflectivity, medium reflectivity, alterations here in the choroid. And this is classic of metastatic tumors. And basically, they don't have internal vascularity. Okay, and usually metastatic tumors do have serous retinal detachment. Choroidal melanomas, they usually do not have retinal detachment. They could have, yes, but it's not common. And as different as the other tumors that we mentioned already, the internal reflectivity of the choroidal melanoma is medium to low. And when it breaks through Brooks membrane, it gives this mushroom shape, breaks through Brooks membrane. And look at this lady, 84 years old, visual acuity 20/40. And we saw when we mapped the retina, we saw this lesion and we did echography and we see classic, this dome shape breaking through Brooks membrane, starting to do the mushroom. But the internal reflectivity is very homogeneous, low to medium reflectivity. And especially the only tumor that talks to the echographers, I am a melanoma, is the choroidal melanoma. Why? Because it has very high, very intense internal vascularity. Though, when it breaks through Brooks membrane, also you can have the mushroom shape. But when you only have the dome shape and you have doubts, do the dynamics. The dynamics is very important. And the choroidal melanoma is the only one that has internal vascularity. This is another case, which is an interesting case. We did all the measurements. We did measurements at the base, anterior, posterior, and we also examined the orbit. It doesn't matter the size of the tumor. You have to do an exam of the orbit. Why? Because it could have extrascleral invasion. And when it does have extrascleral invasion, the treatment changes dramatically. So always have to do extrascleral examination. You cannot just concentrate in the internal part of the eye. Why do I insist in doing the proper techniques? This is a patient, young patient, with a melanoma, and we measured 4 millimeters. We measured the base, anterior, posterior. We send it for brachytherapy. The color changes, like the internal reflectivity changes, no more internal vascularity. And using the same techniques, we measure at the same point to see the evaluation of the patient. So it's not only for diagnosis, it's also for follow-up. And this is also 1 year afterwards. You can see it was gone, practically the tumor. We see the hot coagulation as well, but no thickness present at the echography. And remember, always do the examination of the orbit to see extrascleral invasion. Difference between melanoma and metastatic tumor. First, internal reflectivity of melanoma is low to medium. Vascularity present. And usually do not have serous retinal detachment. Metastatic tumor usually is irregular, internal reflectivity high, medium, low, very irregular, and doesn't have internal vascularity, and usually is associated with serous retinal detachment. When we have lesions of the eye, like this neovascular membrane, we can see this disciform lesion that can confuse usually with internal tumor, or PERC can also confuse with melanoma, or detachments of the retinal pigment epithelium, like this one as well. Or we can also use, and have to use, the UBM in this tumor, which has internal vascularity, low to medium reflectivity, and we can see this, and also we can complement with B-scan to see the invasion of this ciliary body melanoma. Well, thank you very much. I'm sorry there is little time for this material. There is very, very complex and very, maybe some other time we can do a more complex and more complete class of intraocular tumors. Thank you very much. Ms. Javier, you.
It was a very insightful talk, and Dr. Javier did explain us the different types of tumors. And Dr. Sevda, since you also specialize in oncology, we would like a word from you.
Yeah, actually, very good presentation, and I want to ask about uh, regression tumors. So sometimes after radiotherapy, we see a stable or even shrinking lesion on ultrasound. And but histology, the tumor is still active. How much can we trust ultrasound regression pattern as a true indicator of tumor inactivity?
So, in my understanding, what I have seen and learned, the exact measurement of the base of the tumor to be done exactly the same way is very important to know whether it is responding to the treatment and regressing as we had expected, which we usually do in plaques. Where so it is because it's a dynamic scan, it is the person who is doing the scan which is the most important thing here, because how one is measuring that tumor and measuring that base of the tumor will give you the correct answer. So I think it's a very subjective finding to know whether your tumor has actually regressed or responded to the plaque which you would have done.
Yes, it's very good topic actually, but we can't trust even only ultrasound, and we have so another option, and sometimes we can't put diagnosis. For example, it is choroidal granuloma or it's just hemorrhage. Because if we don't have the visual, uh, we can't recognize what is this actually, choroidal granuloma or organized hemorrhage. Uh, what about in your practice? I want to ask about your practice. What is the single most reliable ultrasound feature that helps to separate the tumor from the mimicker? For example, hemorrhage, organized hemorrhage.
So I think it would be patient dependent, like the age of the patient, what is the other eye findings, overall history, and if you have angiography findings, that would equally help along with the B scan to pinpoint what it can be. But
Yes.
maybe you can answer it better for all of
Yes,
us.
anyway, it was a very good topic. Different cases and tumors and other. And it's, of course, we should do focus, reflectivity, and every lesion. So ultrasound interpretation, and it's very good topic and important topic.
So all the features, basically the surface reflectivity, internal reflectivity, size, location,
Yes.
how the overlying retina is behaving, all of it will help us to
Main
come
pattern,
down.
yes, correct.
Yeah, come down to our
Very
differentials.
good differentiation about melanoma and metastasis. Very good.
True. Yes.
Yes.
About how you would see a serous detachment in a metastasis, whereas a melanoma might have just the draping retina at the edge of it.
Yeah,
Correct.
actually, unfortunately, in our country, we don't have plaque therapy. We don't have radiotherapy. Yes, and we send. I am sending to India, to Turkey. Yes,
Oh,
usually I send to my mentor. He is also oncologist specialist, Dr. Mahesh, and
Mahesh, yes,
Turkey.
yes.
Yes, it depends on the patient, what
Correct.
patient wants.
Right.
Thank you so much.
Thank you, Dr. Sida. We did have a very insightful discussion today.
Yes.
And I would like to thank all our speakers and our panelists for being a part of it. And the biggest thank will be to Dr. Vaibhav Sethi and his team at Arunodaya District Hospital for organizing this Pan Ophthalmologica, which is like the grandest possible online conference one can have. So, Dr. Vaibhav, thanks a lot, and thank you for having all of us.
Thank you very much, everybody. It was a very nice session and a lovely presentation and good discussion. Thank you so much. Thank you, Dr. Saivda. Thank you, Isha, for good moderation. Thank you, Dr. Adnan, Dr. Anand, Dinesh sir, Asif, everybody. Thank you so much.
Thank you.
Thank you, Dr. Vaibhav.
Thank you. Thank you, Dr. Vani. Thank you.
I think this was the last session, and
Yes.
we'll be, yes, okay.
Good morning or good night.
Yes, good morning and good night. Bye bye, everyone. Thank you.
Thank you.